I am Dr. Rana Green, Director of Ophthalmology here at the Princess Margaret Hospital. Welcome to our very first virtual Ophthalmology Research Day. Our theme is Insight on Eyesight in the Bahamas. We have lined up for you an engaging and informative session with a fine cadre of speakers covering all aspects of ophthalmic care. And we know you are in for a treat. So stay tuned. We will start with a word of prayer from Nurse Sharia Johnson.
Good morning and happy Thanksgiving. Psalms 100 verse 4 and 5 states, "Enter into his gates with thanksgiving and into his courts with praise. Be thankful unto him and bless his name, for the Lord is good. His mercy is everlasting and his truth endureth to all generations." Let us pray. Father, we come this morning first to say thank you for waking us up, watching over and keeping us safe throughout the night. You've brought us here to this place safely and allow our colleagues and associates to virtually come together and share the knowledge which you have adorned them with. We ask that your guidance and protection cover us, direct our speech, that whatever is imparted today, our viewers and participants would leave this platform with a wide view of more information that they can take to their several workplaces. They were a part of a rewarding and informative place. Thank you again, Lord, for keeping us. All who would have come together to facilitate, bless them in a special way for this research day. Where there is fair, Lord, bring boldness to each presenter. May a peaceful spirit prevail throughout these proceedings today. In the mighty name of your Son, Yeshua, the Christ. Amen.
A pleasant good morning. My name is Marcia Swift, and I will be conducting the first segment of this research day. I am excited to present to you our first speaker, Mistress Delarice Russell, Nursing Officer 2. Ms. Russell has given 43 years of dedicated and exemplary service to the Princess Margaret Hospital and Public Hospitals Authority. Over the years, she has gained expertise in psychiatric nursing and worked in both medical and surgical units. Ms. Russell is presently an intricate team member of the PHA Eye Care Center. The Centerville Seventh Day Adventist Church is privileged to have her as a part of their Health and Community Service Department. Let us welcome Nursing Officer Delarice Russell, who will speak to you on the topic, PHA rises to meet the challenge of COVID-19.
Good morning again. Our topic is the PHA Eye Care Center rise to meet the challenge of COVID-19. The objectives: to prevent the spread of COVID-19, maintain safety among clients and staff, educate staff on the importance and the proper use of PPEs and social distancing, to maintain stability of the center with minimal disruption. The year 2020 has plunged the world into a pandemic caused by a novel coronavirus called COVID-19. The Bahamas Ministry of Health dashboard has confirmed that 23.7% of the population has been infected, with a 2.2% of death and 74.1% has recovered. COVID-19 has impacted our daily lives in many ways, including physically, resulting in decline of health, increased illnesses, and death. Psychologically and economically impact, resulting in loss of family and friends to death, loss of jobs, businesses, and homes. The Honorable K. Peter Turnquist, Minister of Finance, stated in his address in the House of Assembly on September 10th, 2020, stating that our revenues declined from 45.5% or to 251.4 million. Social impact. We have been impacted socially, resulting in the government emergency orders being implemented to gain control over the spread of COVID-19. Lockdowns were commenced to limit the numbers of persons attending gatherings, for example, parties, weddings, funerals, and the social assistance from NIB has increased eightfold due to unemployment. The educational system has also been affected, resulting in the delays of national exams. Face-to-face learning has been converted to a virtual learning platform, according to Mr. Julian Anderson, the Deputy Director of Education and Technology. The Department of Ophthalmology was no exception to the impact of COVID-19, resulting in the delay in follow-up appointments, decreased amount of daily clients, delay in diagnostic testings, delay in eye surgery. The eye care center rose to meet the challenges of COVID-19 through collaboration with the management team and staff members, and the following changes were implemented. Establishment of a COVID-19 protocol, rescheduling a patient's appointment, prioritizing visits, creation of a nursing triage and an assessment desk, prioritizing visit, rearrangement of clerical staff, desks for social distancing, provision of adequate PPEs for all staff, thermometers for checking temperatures, blue floor markings indicated 6 feet for social distancing, hand washing station outside and hand sanitizing outlets inside. Poster indicating proper mask wearing, provision of protective shields for the slit lamps, routine cleaning of frequently touched surfaces, and education of staff on identifying the symptoms of COVID-19, hand washing techniques, donning and doffing of PPEs. I will now take you on a tour on a routine day at the Eye Care Center. At the Eye Care Center since COVID-19. The patient is greeted at the door by the nurse, and she ensures that the patient is wearing a clean, well-fitted mask. If there's none, one will be provided. The patients then form a line 3 to 6 feet apart, and the names are called according to schedules. Hand washings are done at the washing station that are placed outside the door. The temperature is checked at the door by the security. A line is formed inside using social distancing once the temperature is normal. Vital signs are done, and the COVID screening questionnaire is done by the nurse. Following this, the patient area is cleaned and sanitized, And then the patient registered at the registration desk. The clerical area is also sanitized after each use. Patient then proceed to the waiting area where they are seated in unmarked chairs, maintaining social distancing. The notes are then brought to the when the notes are brought to the assessment room by the clerical staff after registration. The notes are brought to the assessment room by the clerical staff after registration. The patients are then called for visual assessment and installation of eye drops. They then return to the waiting area until their eyes are fully dilated. They are then called for visual exam by the doctor. On completion of the exam, they are given an appointment, a prescription, or referral, and then proceed to the clerk, who provides them with an appointment when they leave. The equipment and the room is sanitized after each patient using hospital-grade disinfectant, and hand washing protocols are adhered to by the nurses and the doctors. And thank you. Questions?
Thank you, Sister Russell, for giving us insight on how the Eye Care Center focuses and builds on creating a safe environment for both staff and clients to prevent the spread of COVID-19 with continuity of care. Our next speaker is Dr. ANITA Dean Brown, optometric doctor. Dr. Dean is a U.S. certified optometrist. She has graduated from the New England School of Optometry in 1992. Dr. Dean opened MJB Optical Clinic on Nassau Street in 2004. Her passion for quality optical care has led her to extend her services at the Luttrell Medical Center. She is married to Dr. Kevin Dean and has 2 beautiful children. Dr. Dean will speak to you on the difference between vision screening and comprehensive eye exam. Let us welcome Dr. ANITA Brown Dean, OD. After Dr. Dean has given her presentation, we will have a short break. Thank you.
Morning to all. Due to COVID-19, this year has been far from what we all know as normal. And with all the restrictions, lockdowns, curfews, as we try to get ahead of this virus, all non-emergency eye care for some part of this year was put on hold. However, even more so now, as COVID-19 has shifted our world to a virtual platform, we need to know and understand the difference between vision screenings and comprehensive eye exams. and the importance of having a comprehensive eye exam to ensure that we have good, functioning vision and healthy eyes, not only for this new season, but for many other seasons of life to come. So let's begin. The differences between vision screening and comprehensive eye exams. So what is a vision screening? A vision screening is really just a short test that was created for the intentions of really just to identify the presence of vision problems or potential vision problems. Many vision screenings only test distance acuity. So therefore, it cannot be used to diagnose any eye or vision problems. So here are some charts that we may be familiar with that we use for vision screenings. And usually screenings are performed in schools, doctor's offices, driving license facilities, health fairs, etc. It can be done by teachers, nurses, pediatrician, family doctors, administrators, etc. But here are some limitations to vision screenings. Statistically, 1/3 of vision disorders can be missed in children when we do screenings. And because screenings are done in different settings, such as lighting, test distances, the results of these tests can vary. There is not really a lot of times a standard measurement for passing. So again, the results can vary. And what I'm talking about is some areas may decide that 20/40 is passing or better. Some places may say 20/30 is passing. So we don't have, we have varying results from that. And also vision screenings can give patients a false sense of security, because if you tell them that they passed, they feel that everything is okay. They don't need to do anything else. And that can cause us to miss problems that are underlying and exist. Vision screenings also can be very difficult in younger children under the age of 4. So what is a comprehensive eye exam? This exam can only be performed by an eye care professional, like an optometrist, an ophthalmologist. And it is done in a controlled environment with specialized equipment that allows us to evaluate the eyes and make diagnosis and prescribe treatment. So what can you expect when you get a comprehensive eye exam? Some tests that are included are patient history, vision acuity, which is done both far and near, or distance and near. Our preliminary testing, where we test eye muscles, color vision, peripheral or side vision, neurological issues, where we test the pupil's reaction to light and depth perception. We also do refraction, where we can determine if there's any refractive errors like nearsightedness, farsightedness, astigmatism. We also check the functionality of the eyes in terms of how the eyes work together, testing accommodation to see how the eyes can shift from one direct distance to another, binocular vision, where we're checking to make sure the eyes can work together, and ocular motility, where we're checking how the eyes move together. We do the health evaluation of the eyes. And some of the things we're doing is tonometry reading, where we're checking the pressure of the eyes to make sure that there's no glaucoma. We're doing external exams where we're looking at the lids, the lashes, cornea, conjunctiva, and all surrounding tissue using the biomicroscope or slit lamp. And here we can evaluate if there's any corneal edema, if there's any conjunctivitis, dry eyes, cataracts, etc. Then we do internal exam, which is usually done on a dilated pupil. And here we're looking at the retina, the back of the eyes, to ensure that there's no disorders. Things that can be diagnosed here is like diabetic retinopathy, retinal detachments, cataracts, because we actually can see the cataract better on a dilated exam. So these are the kind of things that we're looking to evaluate. So you may ask, how frequent should I have my eyes tested? And the recommendation is that if you're asymptomatic or this risk-free, that a child should have their eyes first tested by the age of 3, then again before they enter grade 1, and every 2 years thereafter. Once you've reached the age of 40, it should be annual. Now, for people that have symptoms or there are risks, the doctors at that point will decide how frequently you need to have your eyes tested. So here ends my presentation. And I want to say thank you for having me here. Any questions? If not, we move along. Thank you.
Dr. Dane, thank you for providing us with insights on the difference between vision screening and comprehensive eye exam. I am sure that your presentation has brought much clarity to our viewing audience. We will now take a short break. Dr. Anna Bastian is a senior house officer of the Division of Ophthalmology at the Public Hospital Authority. She has gained a Bachelor's of Science and Medical Doctor's degree at the University of the West Indies. Dr. Bastian has also acquired a Bachelor's of Chemistry degree at the Florida Memorial University. She is happily married and the proud mother of 2 beautiful daughters. She will be speaking to us on the prevalence of eye trauma secondary to violence during the 3-month lockdown of COVID-19 pandemic in the Bahamas. Join me as you welcome Dr. Anna Major Bastian.
Good morning. I'm Dr. Anna Major Bastian, and today I will be presenting a pilot study that was done in the Division of Ophthalmology at the Princess Margaret Hospital entitled Prevalence of Eye Trauma Secondary to Domestic Violence During the 3-month Lockdown of the COVID-19 Pandemic. There are no financial or other disclosures to report at this time. Since the COVID-19 pandemic, the entire globe has felt the various unprecedented fallouts, whether through lockdowns, via travel restrictions, or through financial losses by way of unemployment and business closures. Interestingly, during this time, there has been increasing reports of domestic violence and child abuse worldwide. According to the Minister of Social Services, the Bahamas has also seen an increase in reports of domestic violence since the beginning of the COVID-19 pandemic. In particular, there were also incidences of domestic violence related eye injuries during this time. So our objective for this study was to evaluate patients presenting with eye injuries associated with domestic violence during the 3-month lockdown period of the COVID-19 pandemic in the Bahamas. While this is the first study locally to evaluate the relationship between eye injuries and domestic violence during the COVID-19 pandemic, a number of other studies have published to date in countries across the continents, such as China, Australia, the United States, South Africa, the United Kingdom, Italy, France, and Brazil. These studies have documented increases in domestic violence rates and child abuse rates, and have also documented an increase in eye injuries secondary to a number of factors such as home improvements, manual work, burns from chemical or corrosive substances, and also from interpersonal conflicts. Locally, a study published by the Inter-American Development Bank also documented an 11% increase in domestic violence in the Bahamas during this period. To the best of our knowledge, this study will therefore be the first in the Caribbean to evaluate eye injury secondary to domestic violence during the COVID-19 lockdown period. This was a retrospective study that audited the medical records of patients presenting with eye injury to the Princess Margaret Hospital during the period of March to June 2020. The information extracted was done in a private setting and included measured variables such as patient demographics, clinical presentation, and the nature of eye injury. The collated data was evaluated using statistical analysis. There were 12 participants in total for this study. Firstly, we evaluated the socio-demographics of the participants, beginning with their age. We found that 75% of the participants were adults and 25% were minors. The youngest patient was 3 months old and the oldest was 45 years old. The mean age of the participants was 23.6 years old. As for other social demographic characteristics, 75% were females. All participants were of Black ethnicity. 83.3% were of Bahamian nationality. And 50% of the eye injuries were inflicted by a partner. Of note, at the time of this study, none of the participants were officially married. Regarding the eye involvement, the right and left eye were involved equally among the participants. And in 16%, the injury was extensive enough to involve both eyes. The range of eye injuries were from lid swelling and black eye to sight-threatening globe rupture, with the most common eye injury being lid swelling and subconjunctival hemorrhaging, which accounted for about 50% each. Facial bone fractures accounted for the majority of other anatomical injuries, with orbital bone fracture, which are broken bones around the eye socket, being the most common type. Similarly, hemosinus, which is an accumulation of blood in the sinus cavities, was another common injury. 17% of the participants with extensive sight-threatening injuries required ocular surgery, whereas 83% did not. The time from injury to presentation showed that the majority of participants presented within 24 hours. However, 8.3% of participants presented as late as 3 weeks from the time of injury. In conclusion, to the best of our knowledge, this is the first study in the Caribbean to demonstrate a relationship between eye injuries and domestic violence and child abuse, specifically during the lockdown period at the height of the COVID-19 pandemic. Secondly, we found that 23-year-old unmarried Black Bahamian females were the persons at greatest risk for eye injuries, particularly lid swelling and subconjunctival hemorrhages, secondary to domestic violence during the COVID-19 lockdown period. Of note, I would also like to say that although most victims presented to hospital within 24 hours of their injury, we found a few that had delayed reaching out of ophthalmic care during this lockdown period. This study highlights the need for enhancing conflict management skills among the general public. This study also highlights the need to ensure the general public is made aware of local victim and family support services, such as the Women Crisis Center. Additionally, the public should be educated about the importance of seeking prompt ophthalmic care to prevent ocular morbidities. These are my references, and I would like to acknowledge the clerical staff at the Eye Care Center for assisting with the medical records of the participants, and also Mrs. Hamilton, the librarian at UWI and PMH, for her assistance. Thank you so much. Any questions?
Excellent presentation, Dr. Bastian.
Thank you.
My question is, I listened, was there any incidents with those trauma of traumatic iritis?
Yes. Most of the participants had traumatic arthritis. Let me pull up that slide for you. Well, 25%, if you would look on the slide here, look at the forward graph, 25% had traumatic arthritis. Thank you for the question. Any other questions? Okay, thank you.
Congratulations, Dr. Bastian, on your research evaluating domestic violence and abuse during secondary to COVID-19 lockdown pandemic in the Bahamas. We will now move to our second segment.
Good morning, everybody. I trust that you're all enjoying the event so far. We've had excellent presentations, and that's been fantastic. So at the moment now, we're going to move to our guest speaker. It's Dr. Yvonne Bice from the University of Toronto, Canada, and she is joining us from Canada by Zoom, and I will introduce her. I know her personally, working as a glaucoma fellow for 2 years at Toronto Western Hospital. Dr. Baez is the full professor at the Department of Ophthalmology and Vision Sciences at the University of Toronto. She was also elected as the 68th president of the Canadian Ophthalmological Society, the COS. She obtained her medical degree, ophthalmology residency, and glaucoma fellowship at the University of Toronto. Dr. Baez has been actively involved in numerous professional organizations, inclusive of being on the editorial board for the Journal of Glaucoma, being a past glaucoma section editor for the Canadian Journal of Ophthalmology, and also being a past president of the Canadian Glaucoma Society, as well as the Toronto Glaucoma Society. Dr. Baez was instrumental in Canadian policymaking through the Canadian Ophthalmology Society over the years in implementing a number of policy-making guidelines, inclusive of evidence-based clinical practice guidelines for the management of adult glaucoma, providing a policy statement on the medical use of marijuana for glaucoma in 2010, and also a policy statement on the medical use of cannabis for glaucoma in 2018. She's also been instrumental in 2020 in producing a practical guide for adult glaucoma in the setting of pregnancy and breastfeeding. Dr. Baez is a principal investigator on many research endeavors. She's published over 170 peer-reviewed scientific papers, 16 invited editorials, and 10 book chapters. She has designed and implemented as an educator a unique and comprehensive introductory course for ophthalmology residents at the University of Toronto. And she received for all of her work an Achievement Award from the American Academy of Ophthalmology in 2015. Dr. Baez has agreed to do our very first Dr. Steele Perkins lecture, and we welcome her. Thank you.
Is your patient's position affecting their glaucoma? This presentation comprises a lot of work that I've done over many years with also many collaborators, including Dr. Green, as you will see in a few minutes. And these are my disclosures. So there are a number of glaucoma risk factors that have been well defined. These include ocular factors, such as disc appearances, abnormal discs, disc notching, disc hemorrhages, pseudoexfoliation, pigment dispersion, myopia, corneal thickness, and variations in intraocular eye pressure over time. And then we have our non-ocular factors, and these include things like aging, your genetics, race, migraines, and steroid use. Now, despite recognizing all of these risk factors, in 2020, we still have only one risk factor that we're able to modify in the management of glaucoma, and that's intraocular pressure. Intraocular pressure, as I mentioned, can vary over time. And one thing that we don't really talk very much about is the influence of body position on intraocular pressure. And that's what I would like to spend the next bit of time talking about. It's often wondered, why do people who have what we call quote unquote normal intraocular pressures progress over time? And I'm sure you've all seen these kinds of patients. Well, one of the things is our definition, not of normal intraocular pressure, but how we measure it. And we normally measure it only during business hours, 9 to 5. And typically we measure it in the seated position. And as I mentioned, we know pressures can change by position. This study here, which was published in 2003 by Dr. Weinred's group, shows exactly what I'm talking about. So here they had two groups of patients that are illustrated. The filled symbols are untreated glaucoma patients, and the open symbols are the control patients. And their pressures were measured through a 24-hour period in either the seated position, which is the circular ones, or in the supine lying position. And you can see that the patients that were in the supine or in the sitting position at nighttime, when they would lie down, their pressures dramatically increased. So this was a very important paper at the time that it came out. And in fact, sorry, I'm just trying to move something here. The intraocular pressure increases when lying flat were about 6 millimeters mercury in both normals and controls. So we know that your eye pressure can go up about 6 millimeters mercury when lying flat in both normal patients and glaucoma patients. And we spend roughly 1/3 of our day lying in this supine position while we're sleeping. So the question we thought of, well, could this supine pressure rise during sleep play a role in glaucoma progression, and specifically in those patients whose pressures seem to be normal during office hours? So as we were thinking about this, we thought, how could we potentially modify the pressure in the sleeping position? And this study we published in Ophthalmology in 2010. We took a group of glaucoma patients who were progressing, and these were with normal or good pressures. And we defined progression as the appearance of a disc hemorrhage, and we invited them to participate in this study. So this was 2 nights spent in a sleep lab. One night, the subject would be lying flat, and the second night they would return and they would sleep with their head raised 30 degrees. And we did this by using a wedge pillow. And we would measure their pressures through a period of time. And here you can see the results. The dark line on the graph is the pressures that were measured when they were sleeping in the flat position. And the lighter line is when they were sleeping with their 30 degrees head up position. So from 6 p.m. until the patients were sent to bed, you can see the pressures were quite similar between the 2 groups. But then during the sleeping period, you can see that those in the flat position had significantly higher pressures. In fact, there was a mean pressure increase of 3.2 millimeters mercury when they were supine flat as compared to 30 degrees head elevated. We had a total of 17 subjects in this study. All except one showed a supine rise in intraocular pressure when sleeping compared to their 30 degrees head up. And in 1/3 of these subjects, the magnitude of the pressure reduction by having their head elevated was 20% or more. And I think that that's quite substantial when you consider that most medications, that would be quite a good drop in pressure, 20%. The Journal of Glaucoma in 2014 published this paper by a different group of authors where they mimicked our study. One difference that they made, however, was that they only used 20-degree elevation in intraocular pressure. Their results were quite similar to ours, and they reported overall when the eye or the head was raised 20 degrees at sleeping, that the change in intraocular pressure was 1.5 millimeters mercury lower. So a lower magnitude difference, however, there was a lower magnitude of head elevation. This study included both glaucoma and controls, and they found this effect of lowering the eye pressure in the head up position to be present in about 83% of the subjects, and in roughly 1/3, the degree of the decrease in eye pressure by having one's head 20 degrees elevated at nighttime was more than 10%, so quite substantial. This is another interesting study that also lends support to this idea of sleeping position potentially aggravating glaucoma. So this was a survey by Robert Rich's group of almost 700 glaucoma patients. And they were trying to correlate your preferred sleeping position with asymmetric visual field loss. So as we've just talked about, when you have your head in a more dependent position, lying flat, your eye pressure increases. Similarly, if you lie on your side, your dependent eye will have a higher pressure than your other eye. So in this study of about 700 patients, they found that 430 had asymmetric vision loss. The majority of these patients were normal tension glaucoma patients. And if you look down to the bottom of this graph, you can see that in 66% of the normal pressure glaucoma patients, the greater amount of loss was in their dependent eye. And in the other group, high tension glaucoma, in 72%, the greater amount of visual field loss was also in their dependent eye, suggesting, that this might be something of importance. So habitual sleeping position might be associated with visual field loss. I'm going to now switch gears to other things that involve position changes. And one of these is prostate surgery. And I know Dr. Green is going to be talking about this in much more detail later on today, so I will only go through this briefly. So in patients who undergo prostate surgery, they're usually in a reverse Trendelenburg position. That means their head is significantly lowered. And there have been reports of patients after surgery waking up with loss of vision. And this has been presumed due to posterior ischemic optic neuropathy. There have also been studies that looked at visual field changes associated with laparoscopic surgery, and they reported that 28% of patients had significant visual field losses after surgery. This graph is from another similar study where patients undergoing surgery had their eye pressures measured periodically from the time of lying down to induction and then into the steep Trendelenburg position, which basically extended from T3 to T8. And you can see here that there's a time-dependent rise in intraocular pressure in the Trendelenburg position. This is very similar to that graph I just had shown you from Dr. Weinreb's study. So again, I don't want to take away from Dr. Green's presentation, but we looked to see if giving a IOP lowering medication could blunt that rise, which unfortunately it did not. But in this study of patients undergoing prostate surgery, again, you can see these very significant rises in intraocular pressure that occur when their head is in the steep Trendelenburg position, reverse Trendelenburg. What determines intraocular pressure? So we all know that aqueous humor flow, so the amount of aqueous humor produced from the ciliary body contributes to intraocular pressure, but also the outflow through the trabecular meshwork, and that's really limited by episcleral venous pressure. Other determinants of intraocular pressure include choroidal blood volume, and I think the dramatic example of that is suprachoroidal hemorrhages when the eye pressure becomes significantly elevated, and things pushing on the eye, like extraocular muscle tone. So this made me start thinking about what causes postural changes in intraocular pressure. And I think the most obvious one to consider is raised episcleral venous pressure. Arthur Sitt's group did a study where they measured episcleral venous pressure and changes in intraocular pressure And if it was only the rise in episcleral venous pressure that was responsible for the postural intraocular pressure increase, you would expect the changes, the magnitude of the changes to be equivalent, but they were not. So another theory is that choroidal vascular engorgement, secondary to redistribution of body fluids, might also be responsible for some of the postural changes in addition to the effective episcleral venous pressure. So let me take a step backwards. There's a lot of literature that shows an association between obesity and intraocular pressure elevation. And this is a summary of just some of the studies that have been published on this. The theories for rise to intraocular pressure and obesity include a mechanical theory and a vascular theory. In the mechanical theory, it said that this could be due to the pressure from an increased intra-abdominal pressure, excess intraorbital fat tissue, and your increased body fluids causing an increase in episcleral venous pressure. The vascular theory suggests that changes in blood vessel tone related to insulin resistance might be a cause for the elevated intraocular pressure associated with obesity. So this concept of increased body fluids, increased episcleral venous pressure is similar to what we were talking about could happen with postural changes. So this made me think that if this is the case, in obese patients, we should see an exaggerated postural IOP change. So I mentioned Arthur Sitt. This is another study that Arthur Sitt did where he measured intraocular pressure with a patient sitting at a slit lamp and had the patient with their head neutral and then flexed, extended, then had the patients lie flat and measured their pressures on the left and right side with, I believe it was with the tono pen. And compared to the neutral position, intraocular pressure was significantly higher in all of these other positions, flexion, extension, and all the recumbent positions. So we decided to copy this experimental design and do a study with obese patients, morbidly obese patients, and our control group was normal weight patients. And for all of these positions, we also added lying with their head 30 degrees elevated, similar to the study that we had done and published in 2010. So here you can see our findings. Our findings were the same for the left and right eye, so I've just depicted the right eye here. We had a total of 25 normally weighted patients and 25 morbidly obese patients. And you can see that in the obese group, those are in the blue bars and the controls are in the orange bars. And the stars show when there was a significant difference from the baseline in the neutral position at a P of 0.05. And then overall, if you look at the two groups, you see the blue bars are always higher than the orange bars. And it was a mean of 2.5 millimeters mercury higher intraocular pressure in the obese group as compared to the controls. Also, I just wanted to highlight that going from a flat to a 30-degree head-up position, the pressures were significantly lower in both groups, in the head-up compared to flat. What we were interested, though, was in the magnitude of the intraocular pressure change. And here you can see the magnitude going from the neutral position to the other positions. And unfortunately, this did not support our hypothesis. There was no difference in the postural response between the bariatric group and the control group. In any case, we asked the bariatric group to return. They were all undergoing bariatric surgery, and this group ended up losing a mean of roughly 50 kilos. It was 49 kilograms That's 30% of their body weight. So before surgery, those are the darker bars, and the lighter bars are after their bariatric surgery with significant weight loss. And one thing you can see here is that there is a significant reduction in their intraocular pressure after weight loss. And the mean was 1.6 millimeters mercury. When we correlated that with the amount of weight reduction, we found that a 10% drop in body weight correlated with a 1.4 millimeter mercury decrease in intraocular pressure. And another measurement is a 10 unit decrease in BMI correlated with a 2.4 millimeter mercury reduction in intraocular pressure, suggesting that losing weight is another mechanism to lower intraocular pressure. This is a study from another group, which is quite interesting. They looked at 125 subjects of various BMIs, and they were measuring their eye pressure in the sitting and supine position, again looking for an aggravated or exaggerated postural change related to weight. Overall, they found that pressure increased 1.3 millimeters mercury when going from a sitting to supine position, but the BMI did not affect the amount of the postural change, so similar to the outcome from the study I just presented. They did, however, find that intraocular pressure did increase as BMI increased, and for every 10 unit increase in BMI, they found a 0.55 millimeter mercury increase in intraocular pressure. Further support that lowering intraocular pressure could reducing weight could lower intraocular pressure. All this time I've been talking about intraocular pressure as we commonly think about it. That's the transcorneal pressure gradient. But those of us who study glaucoma realize that's only a surrogate from what we're interested in. We're really interested in what's called the translaminar pressure gradient, because that's where all the action is happening in glaucoma. That's something that's not possible to measure in a normal situation. So that's why we use as a surrogate transcorneal pressure gradient. But getting back to this translaminar pressure gradient, that's influenced by the intraocular pressure, and behind that, the dynamics of cerebrospinal fluid pressure. So we wanted to try to see if the postural changes that we found with intraocular pressure, were they also happening with cerebrospinal fluid pressure? Because if the changes were correlated, then perhaps the influence on the optic nerve of these changes in intraocular pressure were maybe not as important. So very hard to measure cerebrospinal fluid pressure. At the Toronto Western Hospital, we have a large neurosurgical unit, and they have some patients that are admitted mostly after subdural hemorrhages that have an extraventricular drain inserted. So they're measuring in real time patients' cerebrospinal fluid pressure. So we had a cohort of these patients, a total of 16. They were equally distributed by sexes, 8 females, 8 males, with a mean age of 52 years. When these patients were stable enough, we had the patients measure their intraocular pressure in a flat lying position and also in a sitting position. So you can see here the results for each of the 16 patients. The blue bars are their intraocular pressures when they're sitting, and the orange bars are when they're lying flat. So the expected postural rise, however, only was found in some of the patients. So that's patients 5, 7, 9, and 13. Overall, the mean increase was about 1 millimeter of mercury, but it was not statistically significant for the entire cohort. The same we found for cerebrospinal fluid pressure. while in some patients, like patients 12 and 16, we saw a supine rise in cerebral spinal fluid pressure. In patients 4, 8, and 9, the cerebral spinal fluid pressure was actually much higher in the seated position. So again, we had no common trend. We were interested, as I mentioned, in the translaminar cabrosa pressure difference, which was also, as seen on this graph, not consistent with postural change. For example, you have patient 8, where there's a much higher translaminar pressure difference in the supine position, whereas in patient 12, it was actually lower in the supine position. This graph focuses on the change in the translaminar cabrosa pressure difference. Upward bars depict cases in which the translaminar cabrosa pressure difference was higher in the sitting position, and downward but depicts cases when the translaminar cabrosa was higher in the supine position. As you can see, it is basically evenly divided 50-50. So we had 6 patients where it was higher, in 6 patients it was lower, and in 2 patients there was no difference. So in summary, I know a lot of our patients want to look for alternative therapies in glaucoma. We have very good treatments with combinations of laser, surgery, and medications, but still patients are asking for other things like marijuana, acupuncture, doing yoga, which we now know is probably not a good thing in the head down position, but there's a lot of evidence showing that meditation can lower intraocular pressure, and then herbal things, blueberries, ginkgo are common. But perhaps we should start thinking about sleeping in a head-up position, because this may be an effective, inexpensive, and non-invasive adjunct in lowering intraocular pressure in glaucoma management, and specifically for that cohort of patients that continue to progress with good intraocular pressures. If you are going to recommend this, it's important that you suggest either elevating the head of the bed by using books under the head of the bed frame to elevate it evenly, or using a wedge pillow, because you really don't want to have their head elevated by patients actually flexing their neck, because that could cause other issues with breathing, etc. Also, it would be, I think, beneficial to minimize sleep-related body postures or supine body postures during non-sleeping activities, such as reading, watching television, sunbathing, and yoga. So I would just like to end here by thanking the various contributors that have been involved in these studies. These take a lot of time, a lot of people, and you can see Dr. Rana Green, she was involved in several of the studies that I presented, and the other participants are listed here as well. Thank you, and I'm available for any questions.
Thank you, Dr. Bice, for that excellent talk and summary of all of that work on the impact of position on intraocular pressure. Fantastic. Do we have any questions? Okay, thank you very much, Dr. Bice. We appreciate you taking the time to share your knowledge and experience with us. Thank you. To take a short break, and then we will move on to the introduction of our next speaker. Thank you.
Mrs. Patrice Hanna is a brave and energetic registered nurse. She has acquired an Associate of Science degree in nursing in 1999. She is a certified ophthalmic specialist nurse from the Royal College of London in 2011. Nurse Hannah has shown her bravery and dedication by rendering her services on the COVID-19 frontline team. She is married with 3 beautiful children. She will take you on her journey as an ophthalmic nurse on the front line. Let us welcome Nurse Patrice Hanna.
Good morning, everyone. We want to get right into it. Thank you for the introduction, Nurse Swift. And we want to get right into it. So you can go ahead and just play the video. Thank you, and I hope you enjoy.
And we're here today with Staff Nurse Patrice Hanna, who's a certified ophthalmology nurse. She's completed her training under the Royal College of London in 2012, and she's now assigned at the Eye Care Center on Soldier Road, which is a part of the Surgical Area 1 of the Princess Margaret Hospital, Public Hospitals Authority. And so today, as we celebrate Ophthalmic Research Day 2020, we will be having a discussion with Ms. Patrice Hanna on her journey on the front line in the COVID pandemic. My name is Patricia Newbold, and I'm the area supervisor with responsibilities for the ambulatory care department. And it has been a pleasure working with Staff Nurse Patrice Hanna in the accident and emergency department prior to her training as an ophthalmic nurse, during her training as an ophthalmic nurse, and as a worker on the front line as an ophthalmic nurse. And so this morning, I say thank you very much for the service that you provided to our people. And I wish you all the best. Ms. Hanna, can you take us on a journey of your experience working on the COVID front line, beginning with your very first day?
Okay, my very first day, I was excited to serve. I was excited to be out on the front line. I was not afraid at all. But being out on the front line for the first day meant we had to try. It was like trial and error, because we had persons still coming into the hospital for different reasons. Some were coming because they needed medication from the pharmacy. Some came because they had medical issues and they needed to see the doctor. Some came and they needed to be directed as to where they should go to get care. So it was trying to work through the midst of all the confusion and try to make everything go smoothly. We didn't want to leave anyone out, so we were trying to just sort things out, as it were, in this pandemic as to how we should proceed with care at the hospital.
And were you afraid at that time?
I was not afraid at all. I was just open to just giving my service. The pandemic was new. I heard about it on the radio, on the television, different medias. It was new, but I wasn't afraid at that point in time. I was not afraid at all.
So take us through your specific journey as a person, because I'm quite aware that you were actually at the doorway, at the entrance, prior to the persons even receiving care at the triage station. So take us through that and the PPEs that you would have worn during that time. Take us through that journey.
Okay, yes, I was at the front door. And my first day, I didn't have on any PPEs. I didn't wear any mask. I didn't have a gown on. But later on during the week, I was informed that we should wear PPEs. We should wear personal protective equipment. So I was given a mask to wear, a hair covering, shoe covering, a gown, or even an overall.
So as a trained ophthalmic nurse, were there any patients that required ophthalmology care as a result of the pandemic or throughout the time that you were working on the front line?
Definitely. We had patients who came in seeking ophthalmic care. They came in with different reasons. different eye issues. They wanted to see the doctor, so the patient would have been triaged. We would send the patient to see the doctor, but before that, we would do a COVID screening. We had a COVID questionnaire. We would ask each patient, and then they would be assessed by the doctor, and then the doctor would decide whether the patient should go and see an ophthalmologist or see the A&E officer and then be referred. And we had other patients who actually came with an appointment or with follow-up. They had a follow-up with the ophthalmologist. And what we would have done, what I would have done is that I would call the ophthalmologist who was on call that day and let them know that the patient was there. Most of the time, they expected the patient. And then we would do the COVID screening on the patient, and then we would direct them to the ophthalmologist so that they can have their follow-up or their appointment.
So dealing with this virus that is so deadly, can you say to us what has been put in place at the ophthalmology clinic or the eye care center for, I guess, providing care to those patients in this COVID pandemic era? What would have been some changes that may have been put in place?
Okay. Two things I've noticed. We had the hand washing equipment placed in the front at our triage at the hospital. It was also placed at the eye care center for the patients there as well. So when the patient comes to the eye care center, they would wash their hands before they proceed to the door. They would wash their hands, then they would get their temperature checked, and we would let them inside, and they would sanitize as they come inside as well, and they would join a line to have their COVID screening done, and they would also be 3 to 6 feet apart from each other. They have their COVID screening done, and then they would be registered, taken to the back where they would have their eye assessment done and be seen by the doctor. Now, when they are being seen by the doctor, we place a shield, a protective shield on the slit lamp. We never had that before. And we do have that now in place where the doctor will use a protective shield to just extra precaution to protect them from the coronavirus if they do have it. That's just an extra protection that we use. Also, we also sanitize the equipments on the room after the patient leaves the room.
Excellent. And so I understand that even though you worked on the front line at the entrance of the Princess Margaret Hospital, that you also volunteered your services to work with the isolation, we call it the isolation area, where there were patients who were under investigation as well as patients who were positive with the coronavirus. So tell us a little bit about your history there.
Well, working with persons we call PUIs who are under investigations or persons who are positive makes you want to take even more care, makes you want to wear your protective equipment, personal protective equipment, always keep your mask on, keep your shield on, keep on all your protective wear, because you know that the patients are positive, you know what you're going to deal with. So it's and in this case you're not afraid now because you know you're not wondering what is going on with the patient, you know. So you have the upper hand that you should take the necessary precautions to care for your patients the way and to protect yourself the way you should. Working in the COVID unit was a very humbling and a very sobering moment for me. It made my walk with God even closer than before. It made me even care more for the patients that I come in contact with, because they are, when you look at them, you think of somebody else, someone's loved one, someone's mother, someone's father, someone's aunt, someone's daughter, you know, and they may not be there at their last moment to give them that love or to say farewell, but you're there as the nurse and you have that advantage. So for me, I try to say a prayer with them. I try to leave a word of God with them, either which way, whether they're going to leave. It makes my walk closer to God. It makes me even want the patient to have their walk with God closer. And they normally are really excited to hear anything that you can tell them about God during that time, you know. And I would encourage all the other nurses who would come in contact with them, just give them that encouragement, because believe it or not, they normally be looking forward for it, most of them. So just give that love.
So that is so true, and it's so humbling, because we are aware that the patients are basically secluded, they're by themselves. And so would you want to just expand a little bit more about the actual work environment? What was different about the environment in that COVID isolation unit as opposed to working on a regular ward or at a regular clinic? Any basic specifics that you could point out?
The difference in that environment is that on the regular units, when it wasn't a pandemic, you could spend as much time as you want with the patient. You could go into the room as many times as you want. You didn't have to wear any protective wear. But when you are on the COVID unit with the patients, you only allow limited, limited amount of time to spend. At least they're told like 15 minutes the most before you have too much exposure to the patient. So the time is limited. And you want to, within that time frame, whenever you enter the patient room, you want to do all that you can do within that time. You want to feed, you want to carry their breakfast. If it's breakfast time, you want to do their vital signs. If it's that time, you know, whatever care that you can give, you try to do all of that within that space of time, you know. But you never forget to just share your love with them, because it's different. They look forward every time you go into the room. They look forward to seeing you, because they don't just see people as much as they normally would, given a regular day when it wasn't a pandemic.
And so tell me about your family life. It must have been a strain on your family. So take us through that walk.
Okay, family life. I must declare it was challenging with my family. When they heard about the pandemic, they heard about the COVID virus, and they watch it on TV. It's nothing like I could have just go and tell them, oh, this is not real, whatever. They saw it. They saw people dying in Italy and China, in the United States, all over the world. And so they were afraid. So on a given day when they come home from work, before they used to come and greet me at the door, my kids would be so excited to see me. They would jump all over me before the pandemic. But now, when the pandemic came, everybody was afraid to touch me when I reach home. When I open the door, everybody would be standing back. And so I would have to change my scrubs at the door, and then I would have to go and take it to the utility room, wash them, and then proceed to the bathroom where I go and take a shower. And then after I've showered and get dressed, then they would come and hug me and talk to me. So it was really different. At one point in time, my oldest, she used to get a spray and spray me before I ended up saying, Mommy, you're not going to bring the COVID virus inside here. So it was difficult. It was challenging, but we overcame that. After a while, they got adjusted to it. So it was now like a routine for Mommy to come home, change her clothes, and then wash them and take a shower, and then we communicate.
Excellent. Practicing safety in the home as well.
Exactly.
So during the pandemic, did it affect you in a way that any of your family members or co-workers or colleagues were affected by the COVID-19 virus?
I must say, thanks be to God, I have never been affected or been positive with the COVID virus, and none of my family members has had COVID-19 or died from COVID-19. However, I must say that I've had friends who have died from COVID-19, and I've also had colleagues who actually died from COVID-19. So,
Yes, our sympathies. And so, what would you say to your colleagues who continue to work on the front line as you do yourself in this COVID pandemic? What little nugget would you give them each at this time?
first of all, I would encourage all of my colleagues to always seek the divine power. Always seek God, put God first. For His divine protection over your life as you work on the front line. It is God who keeps us. And while you're on the front line working, please always wear your personal protective equipment. Always don them correctly and always doff them correctly. You're doing this because you want to protect yourself, you want to protect your colleagues, you want to protect your family members, or even the patient or the persons that you may come in contact with, not even on the job. So I would encourage them to please safety first, do your social distancing, keep on your mask, sanitize, wash your hands, and wear your protective wear. And you would be safe.
Very good, very good. I appreciate that. I appreciate this interview. And I'd like to just wish you all the best as you celebrate Ophthalmic Research Day. You're on the front line, you're an excellent nurse, you're a caring nurse. And so I just want to say thank you again for the valuable service that you provide to God's people. Thank you. Have a wonderful day.
Thank you, and it was my pleasure.
Thank you so much, Nurse Hannah, for sharing your experience. We are indeed grateful to you for the invaluable service that you have rendered to the PHA and to the Bahamas. Thank you.
Good morning once again. As we continue our second segment of our virtual presentation of Insight on Eyesight in the Bahamas, I am so pleased with this presentation so far. Patrice, you renewed my faith in nursing once again. Okay, so I'm here to present the second set of presenters. Antonia DeVoe, registered nurse and ophthalmic nurse specialist, completed ophthalmic nursing diploma program with PHA in 2019. She obtained an Associate of Science at COB, 2016 graduate at University of the West Indies with a Bachelor of Science in Nursing. Someone I am pleased to call friend. She's happily married and mother of 2 beautiful daughters. May I present Antonia DeVoe.
Thank you, Nurse Wilkinson. And good morning, everyone. Such a pleasure to be here. And I want to thank the contributors and the hosts of this great seminar, this informative seminar. And I want to thank everyone for listening. So today I'm going to present on behalf of my group. This was a group effort. done by Nurse Valencia Davis, yours truly, Nurse Tamaris Newton, and Nurse Rochelle Simonet. The topic for this research is awareness and knowledge of glaucoma, a survey of patients accessing care in the polyclinics of New Providence. Our acknowledgements also go to these following persons who assisted with guiding us in this research project: Dr. Audrey Lightbourne, Dr. Deborah Fox, Mrs. Sakitha Meadows, Dr. Anthony Frankson, Dr. Pearl McMillan, the Ministry of Health, Public Hospital Authority Ethical Committee, Ms. Vernica Delavaux, Mr. Richardson Desmangles, Mrs. Jen Fernanda Roll, and all of the participants of the study and staff and all of the polyclinics of New Providence. Glaucoma is a major public health problem, being the leading cause of irreversible visual impairment worldwide. Approximately 15% of global blindness is due to glaucoma, and nearly 600,000 people go blind annually. Glaucoma can have debilitating effects and can lead to complete vision loss and ultimately affect the quality of life for individuals. Risk factors for glaucoma includes persons age 40 and over, family history, African, Hispanic, or Asian ethnicity, history of eye injury, farsightedness, nearsightedness, long use of steroids, diabetes, migraines, and high blood pressure. The research objectives are to determine the awareness and knowledge of glaucoma in the polyclinics, and this study was conducted starting in December of 2018, and to determine the selected socio-demographic profile of participants in the study. This study is a quantitative, descriptive, cross-sectional design. And the benefit of this design was to describe the level of awareness of glaucoma of patients accessing care in the polyclinics. This research utilized this design to determine the relationship between variables such as glaucoma awareness and age, education, annual income, marital status, and gender. The study was conducted in 4 polyclinics, namely in New Providence, namely Flamingo Gardens Clinic, Elizabeth Estates Clinic, South Beach Clinic, and Fleming Street Clinic. This survey was adapted from a similar study in North Indian among rural residents. The survey had enlisted 6 demographical components such as age, gender, marital status, income, and highest educational level maintained. And the questionnaire had a total of 11 questions. 112 participants agreed and volunteered to participate in this study. And the inclusion criteria was that of persons aged 18 years and older, gender male and females. Some of the challenges that we found in our study is that we had more females than males, and there was less generalizability in the sample. Okay, so in this study, we had 92 females, which was 82.1% of our sample, and 20 males, which was 17.9%. In terms of education, the highest education level attained in most of the participants were high school, followed by college and university. Most of the participants that engaged in the study were unemployed, which represented 68.2% of the sample. When asking the entry question, have you ever heard of glaucoma? Most of the respondents selected yes, they have heard of glaucoma before. The persons that selected no were advised not to continue with the study. Most of the respondents, in fact, 46 of the respondents, stated that the risk of glaucoma increases with age. 13 of them said they did not know. 66 participants stated that anyone can have glaucoma, while 5 persons said they did not know. 51 participants said that blindness from glaucoma can be prevented. 18 persons said that they did not know. When asked if treatment is possible, 65 participants said yes. Other survey questions: if vision is affected in the early stage of glaucoma, 45 of the participants said yes. They also said, 46 persons also said that family history is a risk factor for glaucoma, and that glaucoma has no symptoms. That was 37 participants. And when we asked if glaucoma is the same as cataract, 37 participants said no. 19 said that they did not know, and 14 persons said yes, it is the same as cataract. When asked what will happen in untreated glaucoma, whether it was surgery, loss of vision, or if they were not sure, 53 persons said that there would be loss of vision. 10 persons said they did not know, and 7 persons said surgery. When asked in this sample if they had had an eye exam in the past year, 35% of the respondents said yes, while 65% said no. When asked what was the source of information about knowing of glaucoma, 38% of those persons said that they have heard of glaucoma through television, newspaper, and radio, while 26% said that they have only heard of glaucoma through a health institution, health personnel, eye campaign, and 36% of persons said that they heard of glaucoma through a family, or relative. Okay, in our study, we found that males were more aware of glaucoma more than females, and this could have been contributed to the size of the sample, where we had more females than males in our sample. In our literature review, Livingston et al. Reported 70% of participants 40 and older had heard of glaucoma, and Krishnan et al. Reported older participants to be more aware than the younger participants. In contrast to this, studies reported that of 340 adults, only 8 persons were aware of glaucoma, and another study lends support to this fact to say that they found that age groups were not associated with the knowledge of glaucoma. Nikem et al. Also suggested that higher education was statistically significant in glaucoma awareness. In conclusion of our study, we found that the older population was more aware, persons with higher level of education, as well as the major source of information about glaucoma was through television, newspaper, and radio. For future research efforts, we would advise that the research be done in all New Providence clinics, as we only targeted the polyclinics, which were Flamingo Gardens Clinic, South Beach Clinic, Elizabeth Estates Clinic, and Fleming Street Clinic, and to use a random sampling method rather than convenience. These are our references. Thank you. Any questions? Or you can post them in the chat. Thank you so much for this opportunity.
Thank you, Nurse Antonia DeVoe, for your research, as well informative. My second speaker this morning is a quiet, unassuming professional who not only lead in her work arena, but is an awesome team player, involves all agent of change, while holding to her belief that if God is at the head, anything is possible. Director of Ophthalmology at PMH, first and only Bahamian glaucoma subspecialist or surgeon to practice in the Bahamas, earned a medical degree at University of the West Indies, Trinidad, completed ophthalmology residency at University of Pretoria, South Africa in 2014, earned a Master of Medicine degree in ophthalmology, University of Pretoria, completed a 2-year glaucoma fellowship at University of Toronto, reviewer of British Medical Journal since 2017. Ladies and gentlemen, it gives me great pleasure to introduce Dr. Rana Green.
Good day, everybody. Thank you again for that kind introduction, Nurse Wilkinson. So, today, I will be presenting my research on the effect of preoperative glaucoma eye drops on the eye pressure of patients who undergo robot-assisted prostate surgery. This research was a collaborative effort with the Department of Urology, Anesthesiology, and Ophthalmology at the University of Toronto, and it was conducted at the Toronto General Hospital. I acknowledge support for this study from the Glaucoma Research Society of Canada. Good. Did you know that there is a relationship between eye pressure and prostate surgery? Well, yes, there is. In fact, it is particularly related to robot-assisted prostate surgery. So let's briefly take a look at how that works. Here you see the Da Vinci robotic surgical system that was approved by the FDA in the year 2000. This is a surgeon's console where the surgeon has control over all of the instruments with three-dimensional high-definition view of your anatomy. This is the patient's console where all of the instruments move in response to the surgeon's hand movements. And this is the vision cart, which enables communication between all components and also allows intraoperative viewing of the procedure. This robotic surgical technique is also used by other specialties. For example, as Dr. Halliday quickly mentioned, for gynecological procedures. So this information that we're presenting today and the information that was presented by Dr. Baez is also useful for obstetrics and gynae cases. Today, robot-assisted laparoscopic radical prostatectomy has become a predominant surgical technique for the management of prostate cancer, which is the second most frequent malignancy in men worldwide. Benefits of this technique, as opposed to conventional or open prostate surgery, include sparing of the neurovascular bundle, reduced blood loss, less perioperative and postoperative pain, and shorter hospital stay. For this technique, patients are required to be in steep Trendelenburg position. As you may know, this means patient lying supine on their back with their head below and their feet elevated. typically at an angle of inclination of 30 to 45 degrees. Herein lies our concern. In this bodily position, there are well-documented reports that the eye pressure in patients more than doubles the baseline. And not only does that, it has the impact of causing loss of vision postoperatively. Several reports have documented that, and some of that you heard today with Dr. Bias. The other thing that is important to us is that there are reports of worsening of the visual fields. You know that diagnostic test that we use routinely to not only diagnose, but to monitor our glaucoma patients? There are worsening of those visual fields. And in some instances, for example, a study published by Takatani, there were 28% of 25 patients, that means 7 out of 25 patients who underwent the same procedure were noted to have new onset visual field defects. So how does this all work? It is believed that the markedly elevated eye pressure as a result of steep Trendelenburg positioning results in compromised blood supply to the optic nerve. And you see a picture there showing you how the optic nerve is really an extension of the brain. So if you really remember this anatomy, we're making it simple. The eye is really a part of your central nervous system. It is an extension of your brain. Not only do you have compromised blood supply to the optic nerve, this results in something we call ischemic optic neuropathy. So that part of your nerve of the eye just didn't get any blood supply. He didn't get his breakfast or his lunch. This results in loss of vision. Okay, that is pretty much the way that it goes. Okay, now that leads us to what were we trying to establish for this study? Our research question here was, can the eye pressure that we know to be elevated for these patients be prevented? That rise in eye pressure, can we prevent it? Particularly during robot-assisted prostatectomy through the use of preoperative brimonidine glaucoma eye drops, 0.2%. And most of you in the room know the trade name for that would be Alphagan. So you know we're all on the same page. We're not the first persons to try to figure out how can we address this. It has been done by others. For example, perioperative dorzolamide or timolol combination, as you may know, a trade name is COSOP, has been used. In that study, they simply tried to do it only when the eye pressure reached a certain level, about 40. That's at Malloy et al. In 2014. A second study chose to assess the impact of using different forms of anesthesia, like propofol-based intravenous anesthesia, as opposed to sevoflurane. Another technique used to address this eye pressure elevation problem was using a modified Trendelenburg positioning. So you see there on the screen, you see the patient laying flat in A, then in B, they put them in the steep Trendelenburg position, and in C, here, you see they are now in a modified steep Trendelenburg position. So the head and the body is not completely down. There were limitations with these studies. So that brings us to our study, which was a prospective randomized double-mask controlled interventional clinical trial approved by the University Health Network Research Ethics Board. For this study, adult males who were scheduled for robot-assisted radical prostate surgery were randomized for one eye to receive either placebo or drug. Placebo in our study was natural tears, and the drug was brimonidine. For each patient, the eyes were examined preoperatively and 1 month postoperatively with a comprehensive eye examination, Dr. Dean, which included visual acuity, eye pressure measurements, optic nerve photography, visual field assessment, OCT of the optic nerve, and vitals, weight and height. For this study, a standardized anesthesia, I think it's moving ahead of me, Dr. Halliday. For this study, A standardized anesthesia protocol was used, and we maintained the Trendelenburg positioning at 33 degrees for each patient, which was a limitation for some of the previous studies. Their angle of inclination varied. So if it varied, it means that their eye pressure readings would have varied. For this study, we kept it constant. I'm going to have to backtrack because it's going a bit ahead of me. For each patient, we did toner pen eye measurements, and you can see in the top hand corner, measurement of the eye pressure with a handheld toner pen. And these eye measurements were made at the pre-anesthesia, or we call it T1, that means before the patients were anesthetized, with the patient anesthetized in the supine position, and we did it every hour with the patient in the steep Trendelenburg position. Once the patient was awake and back flat on their back in the supine position, eye pressures were measured again. So let's look at our results. For this study, a total number of patients were 26. They had a mean age of 61 years. Preoperatively, 11 patients were randomized to receive brimonidine, and 15 patients were randomized to receive placebo. It is important to note that if you see here, the preoperative eye pressure mean was about 18 millimeters of mercury in the brimonidine group, and it was not very different from the preoperative baseline eye pressure for the placebo group of 17. So everything was normalized. At the 1 hour mark, you can see eye pressure rise, mean eye pressure being 29 in the brimonidine group from 18 preoperatively. That's a huge increase by as much as 10 millimeters of mercury or more. Similarly, at the 1 hour mark intraoperatively, the placebo group of patients also had an increase in eye pressure to about 27 millimeters of mercury, a rise of 9.5 millimeters of mercury. So there was very, very little difference. We noted for this study sustained and significant increase in eye pressure with steep Trendelenburg positioning. We also noted for this study there was not much difference with brimonidine. So we got some answers there. We have to note that in a drug-treated eye, the highest eye pressure recorded for this study was 44 millimeters of mercury, and that was at the 1 hour mark. We have another graph that gives us the idea of what it looked like throughout the study. So you see T1 being preoperative, and T-wake means the procedure is finished, and now we are seeing the patient supine and seeing what their pressure levels look like. What you can see at T2 is where they are anesthetized. So you know when we receive our anesthesia, what happens? Everything drops. Blood pressure drops, everything. So you see the eye pressure drops. But now 1 hour in that position, what happens? That eye pressure climbs again. And it remained at that point until time for them to go back in supine position. And you can see very little difference in the main eye pressure reading between the drug and placebo treated groups. Good. And important to note, at the end of the study, everybody's eye pressure returned to baseline. Good. Now, we also assessed additional factors about the surgery itself, inclusive of the duration of surgery. Why that is important, because the longer you stay in that position, the greater the risk of issues. So one recommendation in some of the other studies was to try to limit the time of the surgery. On average, you see here between both drug and placebo groups, 167 minutes, 193 minutes. On average, that works out to about 3 hours. We also look at fluid administration and blood loss. In conclusion, for this study, we were able to establish and support some previous data that there is significant and sustained elevation in eye pressure occurring during robot-assisted prostatectomy with steep Trendelenburg positioning. We were also able to conclude that preoperative brimonidine glaucoma drop did not prevent this rise in eye pressure. So we have some recommendations. Preoperative ophthalmic evaluations for patients scheduled for robot-assisted prostatectomy should include, particularly for patients who are older than 65 And also people who have a family history of glaucoma, they should be having an eye examination. So Dr. Halliday, your patients that are going for those procedures, even the gynae patients, ensure that they go and have a visit for a comprehensive eye examination with their local eye care specialist. Also, we should have careful consideration of surgical patients for prostate surgery or any other surgery requiring the same positioning for glaucoma patients. Be careful what surgical option you recommend for them to have. And I believe that is it. These are our references, and I thank you for your time. Okay. Yes, Sister Russell? Mm-hmm.
Why do we use it? Or is it best to use a combination, or we could just skip not using alpha-GAN?
This is an excellent question, Sister Russell. So alpha-GAN is one, not really a first-line treatment. If you notice, we start off today with prostaglandin analogs. That's like your Xalatan, your Travatan, your Lumagan. But as an alpha agonist, alpha-GAN is very helpful in combination with the other drops. In this study, we were particularly looking at how eye pressure is impacted by alpha-GAN when the patient is in a steep Trendelenburg position. This is not a typical position that people will be in. This is similar to what Dr. Byers had mentioned, people who, for example, do yoga if they stand on their head or they stand on their head for any other reason. So this is not a normal way. So the way how alpha-GAN works in a patient in steep Trendelenburg positioning is different than someone like Dr. Bastian sitting straight up in our normal way of living. So I wouldn't say it doesn't work. It just didn't show the kind of efficacy we were looking for with the patient in that position. Thank you for that question. Yes, Dr. Bastian. Mm-hmm. To God be the glory.
Comprehensive eye examination. Excellent presentation, Dr. Green. My question is, for the comprehensive eye examination, would the pachymetry test or central corneal thickness measurement matter in these patients?
It definitely would. Very good question, Dr. Bastian. And I think you know from working with me, central corneal thickness is an important part of our glaucoma evaluation. And so if you look back at our slides, it was included in our test as well. So yes, it is important. And let me make sure that everyone else is up to speed. When we talk about central corneal thickness, she's talking about the cornea of the eye. And the central part of the cornea is exactly where we touch the eye with the toner pen or with the Goldman tonometer to measure the pressure of the eye. But we have found that some people have thinning of that part of the eye, of the cornea. And that's naturally the way that they are. Or for example, some people have what you may call keratoconus, where the front of the cornea forms more into a cone. In such cases, we believe that the pressure reading that we get is not as accurate as what we would like. So we have available to us a sort of a calculation. It's not foolproof, and there may be some people that have different ways of reviewing that or considering that, but there's a way of calculating what the eye pressure reading is with consideration to the central corneal thickness. We have found overall, the thinner the corneal thickness is in the central area, the higher the pressure reading is that you get. So we have to keep in mind. We also have found central corneal thickness to be an independent risk factor for some individuals to go on to actually develop glaucoma. Excellent question, Dr. Bastian. Are there any other questions? Okay, thank you very much, everybody.
Good stuff. Okay, our next presenter, Dr. Charlene C. Wallace, OD. Board certified optometrist for over 30 years. First Bahamian female optometrist to return to the Bahamas. Earned BSc degree in biology at Concordia University in Canada. 1989 graduate from New England College of Optometry in Boston. In 1990, she opened the Family Care Center, Rosetta and Alexander Street. Mother of one daughter, Symphony. Ladies and gentlemen, Dr. Wallace.
Good morning. Thank you so much for that wonderful introduction. Dr. Green, that presentation was excellent. Okay. My topic this morning is the importance of eye care in a digital world. This is now a hot topic. It's a hot topic as we entered into the year of 2020. The coronavirus pandemic placed special emphasis on the eye. Before we heard 2020 would refer to the standard of visual acuity that we used. But now in 2020, the focus became the eyes in a very central way because everything now was being done virtually. So in this era, from the moment we wake up to the moment we go to bed, our eyes are usually glued to some digital device, either to the iPhone or to our cell phones, to our iPad, to digital devices. Our eyes are glued to a screen on a regular basis. So how are we supposed to be able to function optimally in this world? Despite the fact that our eyes are the window to the world and they cannot be transplanted or replaced, we neglect the care of our eyes. We do not realize the importance of good vision and healthy eyes. For most of us, we just want to be able to see, and preferably without glasses. We're happy being able to state that we could read the 2020 line on a chart. We're happy being able to go to, I'm sure my colleague Dr. Dean explained, we're happy to be able to go ahead and talk about, oh, there's a screening going on and I can just participate in that and I'll be able to determine what's happening with my eyes. Well, that's not so, because there's so many types of eye conditions that can have an adverse effect on our vision and claim our eyesight. As simple as what our refractive error is, such as whether we're nearsighted or farsighted or have astigmatism, whether we have dry eyes, cataracts, glaucoma, macular degeneration or macular conditions, retinopathies, and many others. All of those types of conditions are adverse effects that can happen if we don't take care of our eyes. We cannot be content with the minimum. And by the minimum, I'm talking about an eye screening, where you go ahead and you go to visit your doctor, you go to your general practitioner, you're able to read on an eye chart, you read the line, and you're happy with that. No, we have to have a comprehensive eye examination. Why? The reason for that is it's going to tell us how well our eyes are functioning together. It tells us what we can see, how well we can see it, the health status of our eyes. And so the first aspect of proper eye care is to have a comprehensive eye examination. In that comprehensive eye examination, we are going to have a good history taken. We're going to establish what the visual acuity is, far away and up close. We're going to determine how well our eyes work together. We're going to be able to look at the basic neurological pathways. We're going to determine different wavelengths of light that can be distinguished, because we know that there are certain conditions that can be affected by color vision. We're also going to determine how well our eyes move together, determine whether we have a prescription and what it is, whether you are myopic or hyperopic, or you have astigmatism, or there's keratoconus. We're going to determine the health status of your eye, that's the front as well as the back. We determine whether there is, what the intraocular pressure is, and we actually are able to also reveal the health status of the body, because the eye is the window to our bodies as well. So in order for us to really have good eye health, it is important for us to realize really that our bodies are our eyes, sensory organ that actually gets, it has a greater portion of the brain. A greater portion of the brain is actually dedicated to the eyes, more than the other senses of touch, of hearing, of smell, or of taste. The brain uses our eyes to allow us to see. And as Dr. Green was saying in her earlier presentation, technically, the eyes are an extension of the brain. Eyesight is connected to brain development. And so it is important for us to be able to take proper care of our eyes. 80% of all that we perceive is achieved through our sense of sight. Through a complex process and through special connection with the brain, the eye allows you to see the world around you. Through a simple process and the use of some special devices, an eye doctor is also then able to evaluate your vision and the status of your eyes. And just as you're able to go ahead and your eyes allow you to see the world around you, an eye doctor is able to see what your eyes are like, what the status of it is, what the health of it is, what the condition of it is. So again, we can't diminish the importance of having a comprehensive eye examination, because that is where also we're able to diagnose the various conditions like the cataract and diabetic retinopathy and the glaucoma and macular degeneration. And so it is so important that we go ahead and have a comprehensive eye examination so that we actually can be able to maintain our eyes and take good care of them. But there's another aspect to proper eye care, and that's the nutritional component. People often want to know, is there a special diet that I need to have to ensure that I have good eyesight? Well, it is important that you have a proper balanced meal, and that in your diet or on your average plate, that you do have 3/4 of your plate really being vegetables and 1/4 of it to be meat. But you also want to have the kinds of healthy vegetables, the kind of leafy green vegetables like spinach and collard green that are going to help you in development of the macula, that central area that everything has to focus. Having fruit like blueberries that help in reducing eye fatigue, having things like carrots and apricots, which are rich in beta carotene and that all help to promote good vision. So having a balanced diet is very important, and it does help to promote good health. So you should prioritize your eye health. Now, the constant use of electronics can have an adverse effect on your eyes. And these many things we don't think about, but it is something for us to consider. What are the effects of too much screen time? Your eyes do get tired. They get fatigued if there's too much screen time. Your vision gets blurred. Sometimes you have double vision. You have problems focusing, and you get headaches. Well, believe it or not, these components are a part of a syndrome called computer vision syndrome or digital eye strain. And so this occurs as a result of you focusing your eyes on the computer or other digital devices for uninterrupted periods of times. And then the eye muscles are unable to properly recover for the constant strain and tension. Let's get practical for a minute. If we sit and we cross our legs, how long can you actually keep your legs crossed for without changing that position? So we keep our legs crossed, but we have to change that position. We have to uncross it. But part of the consequences if we don't uncross it is we call it our leg falls asleep. So we get up and we have to move around. We try to wake it up. Well, if this happens to our leg muscles, wouldn't it also be understandable that our muscles are gonna get fatigued? So, but the way the eyes are gonna respond is gonna be different from our leg muscles. The way the eye responds to the fatigue is you get blurry vision, you get double vision, you get intermittent, unstable vision, because that's how it's going to respond. You get blurry glare. You change your position, blurry glare. It's the same thing if you don't give them adequate breaks. So it is important to look at the fact that if you don't give your eyes adequate break, you are going to have digital eye strain. But one of the other things that happens is we don't tend to blink a lot when it is that we are on our devices. And the fact that we don't blink a lot can then lead to ocular surface diseases. The fact that studies reveal that there is up to 66% reduction rate in our blinking whenever we are viewing any digital screens. Anything that demands our attention, we're going to blink less. The less we blink, the more our eyes dry out. When they do dry out, there are consequences, having red eyes, itchy eyes, watery eyes, and it also can result in what is known as dry eye syndrome, where the cornea, as Dr. Green was talking about earlier, the cornea gets deprived of the oxygen because we're not blinking. And believe it or not, there is the fact that when we do blink, the tears are spread across our eyes, giving our eyes the nutrients that we need. If the cornea doesn't get the oxygen that is transported in the tears, then it does become dry. And so we do have that same stippling effect, which can be very painful. So, and it can be controlled with treatment, but why do we have to get to the point of treatment if we only do the things that we're supposed to do? The other thing that can happen is, as a result of inadequate blinking, we can therefore even get inflammation of the eyelids and lead to a condition called blepharitis. All of these can be controlled. Blepharitis can become a chronic condition in that case, but we want to minimize all those kinds of things to happen. So how is it then? What are the kinds of things that we then can do to ensure that we have proper eye care in this digital world? A part of that solution is now going to be in what we call the ergonomics of it. It is going to be important that we go ahead and create a good workplace, good posture when we're sitting down in front of our digital screens. Technically, your computer screen should be at least 20 to 25 inches from you. Now, we're not going to all go and get a tape measure, but if you go ahead and you use arm's length, well, it should be at least arm's length from you. It should be that you have it at proper height so that you can be able, it's slightly below eye level to allow you to be able to look at the screen properly, and you should have adequate lighting. The surrounding light should not be competing with your screen, so you have a challenge to be able to determine, can I really see my screen properly? Also, the font size that we look at is very important. We tend to want to, if we're having a difficulty seeing things, we want to enlarge the font. But the challenge if our font size is too large is you really can't be able to read the words properly. So the size of the font becomes really important. If you're given a prescription, you need to wear it. It's given to you for a purpose, because otherwise you shouldn't have it. There's another rule that's a very simple rule, and it was actually something that was coined by an optometrist in California, Dr. Jeffrey Anschel, and it's the 20-20-20 rule, and I totally advocate that. And it is, after 20 minutes of screen time, look at something that's 20 feet away and look at it for 20 seconds. Now, no, we're not going to go ahead and to get up and measure accurately 20 feet away. But the gist of it, the essence of it is, after about 20 minutes of looking at your computer or at your screen, look far away, look out a window, look out a corridor, and blink a couple times, and then go back to what you were doing. And it's the same thing as we talked about crossing your legs. You're going to cross the legs one opposed to the other. You're going to change those positions. So the important things with the eyes, change the positions. Allow it to be able to go ahead and have a chance to recover so those muscles don't get caught in a spasm. And blink. It is so important that we do blink in all of this. We spend as much time on our digital devices as we do sleeping. The research has shown us that adult screen time is about 8 hours and 41 seconds on a daily basis. Well, the average sleep is about 8 hours and 21 seconds. Studies have shown us that when you use your computer devices or your digital devices before going to bed, it takes you longer to go to sleep because you prevent the hormone melatonin from being able to be released and allows you to be even to help you to get tired and want to go to sleep. So many times you try to wonder, why is it after I came off my device, why is it I have a difficult time going to sleep? You need to give your bodies a break as well. We often wonder, why is sleep important? Well, here's one other reason. Sleep is important. One of the other suggestions is set up a no electronic hour or hours. Many of us with your families do that. Go ahead and stipulate for 2 hours prior to going to bed, no electronic devices. That gives your home and the family time to be able to regroup mentally and physically. And it also gives your eyes a chance to relax. What I would also say is fall in love with your eyes. You know, if we love somebody, we're going to go ahead and we do everything for them. We do everything because we care about them. They are so important. We want to take care of them. We want to show them how much we love them. But fall in love with your eyes. And if you fall in love with your eyes, you're going to give your eyes the best. You're going to ensure that they are properly examined by having a comprehensive eye examination at least once a year. And yes, that includes having a dilated exam, which most people don't like. And also, we're going to help to preserve them because the gift of sight is a precious one, but the loss of it is one we can't go ahead and replace. So I say, fall in love with your eyes and take good care of them. I thank you. Thank you.
I have a 3-year-old, right?
Yes.
In the afternoons, he's be on his tablet quite a bit. So how long you think that I should have let him have it?
You know, many times on those tablets, there's a timer, or even on your phones, there are timers. So you go ahead and you don't allow him to be on that tablet for more than 20 minutes without ensuring that a break is taken.
Thank you. That presentation was awesome.
Thank you.
I felt like I just fell in love with my eyes.
Oh. That's a good thing then.
Yeah. You shed a lot of light on things I actually didn't know. And now that I know, I would put those things into action. Thank you again.
Dr. Wallace,
Yes, ma'am.
we are now in a pandemic where we are having face-to-face learning has been converted to a virtual learning. So at what point or how often would you recommend that school-age children have an eye exam? And how would the ophthalmology department accommodate these school-age children?
Now, I know I'm equipped to handle the first part of that question. The second part of that question, that's a very loaded one. So let me take the first part of that, okay? It is important that you actually have a comprehensive eye examination at least once a year. An eye examination, even if it is that you are prescribed optical devices, if you're prescribed glasses or contact lenses, that does not mean that your glasses or contacts must be changed every year. It is important that we do understand that your vision and your eyes do go through changes. It may be that in a year's time that the prescription would change by the smallest of steps. Okay, so it changes by the smallest of steps, which still allows you to be functional, which allows you to still be able to see clearly. But remember now, a comprehensive eye examination is not just about your prescription. It's about how well your eyes are functioning, and it's also about the health evaluation of your eyes. And so that is why it's important to have the eye examination on a regular basis. Now, in terms of whether we go ahead and change the prescription, the first year you may not have to change that prescription. But if you have a quarter step change the first year, and the second year you have another quarter step change, that may mean you need to change your prescription the second year. But it all depends on what your prescription is, how often your eyes change, and whatever prescription you may be needing in that regard. Now, the second part of your question, how can the ophthalmology department or the eye care department at PMH, how can we go ahead and ensure that these regular exams are happening? We really don't want to screen them. We want them to have eye examinations because, again, they are on these devices. It is a matter of, like I said, it's not just the visual acuity, it's the health assessment, it's how well their eye function, it's how their eyes work together. Now, how the department can be able to accommodate all of those children, if you were able to answer that, I think that's an age-old question from that standpoint. And really, that's not going to be a limitation of just what the hospital eye clinic can do. That is going to be something that, as eye care providers from a nationwide perspective, we're all going to have to be involved with that. And so it is a matter of not just expecting for the hospital or Princess Margaret to take care of that. That's something that we have other providers in the population to be able to assist with that. And that's the best way for that to be able to be handled, because you're going to have the private practitioners working as well as the government facilities working. There's no way that the government facility can handle the entire thing. That's being unrealistic. Yes, ma'am.
Good morning. It was excellent presentation.
Thank you.
My question is, are contact lenses safe to wear, and what is the advantage as opposed to glasses prescription?
If contact lenses were not safe, I can tell you that as an optometrist, I would never prescribe them. I'm sure Dr. Dean would be have the same position. But it's not are they safe, it's what people do. They decide that a contact lens is a foreign device that's put inside the eye. A contact lens is not designed to go in your eyes and stay in there for a month, 2 months, 3 months, or as you feel. So there are certain parameters and guidelines that should be utilized when wearing a contact lens. Contact lenses are very, very much recommended, and they correct the vision. There are even many other uses for a contact lenses. Many times it's acts as a bandage lens in many cases for certain ocular conditions. So contact lenses are very safe, but they have to be used as they should and not as people feel. There are many times that you're going to find there's a difference between the prescription of somebody that has on a pair of glasses versus the contact lenses. And that is why a contact lens fitting becomes very important. That too, people don't understand. And they feel that, well, I just can go ahead and buy some contact lenses at a kiosk somewhere and be able to put them in. Well, if your eyes are important, and if they are the window to the world, and if they are the precious gift of sight, and if you fall in love with your eyes, then you're not going to go ahead and just buy contact lenses from just anywhere to put inside your eyes. You need to have an eye examination. We need to know what the health of the eyes are. We need to know what the prescription is, because a contact lens, when you put it on, it has to be fitted properly. A contact lens must move, which is what a lot of people don't understand. It is important that the tears flow in between that contact lens and the cornea. It is important that that contact lens is fitted properly and that you're able to see properly through it. So a contact lens really is a good device. Now, during the pandemic, the glasses are a better thing to use because it's an additional protective device from that standpoint. But contact lenses are very safe if they are used as they should.
Dr. Wallace,
Yes.
very excellent presentation. I might have missed Dr. Dean's account of what age do you start to do an eye exam on a child?
Really, a child can have an eye examination. Their prescription is usually is established by the age of 3. So having a comprehensive eye examination and there are adjustments that we make when it is that we're dealing with a 3-year-old versus a 13-year-old. But by 3 years old, it's safe enough to have an eye examination. If we think about it, we're sending them to preschool. We expect them to be able to learn. We expect them to be able to learn what the letters are, what the numbers are, how to form them. And if they're not able to see, then how are they supposed to learn these things properly? So 3 years old is a good time to be able to have a comprehensive examination. Okay.
And your digital, about the digital things that we're always looking at, very, very good, because I'm always debating in my home that this should be put down at a certain time. And I'm told, oh, that doesn't make a difference with my eyes. Now I can go home and I can enforce. Thank you
There's
very
a lot
much.
of research in that regard. And so it is becoming a little bit more challenging because of the pandemic and because school and work have shifted and all happening at home. It's that the digital devices are being used for not only for work or for school, then they're also being used as a means of recreation. Then they're using as a means that you give us a reward to a child. So we do have to find a way to balance it. Those kinds of things are becoming important, are very important. There's also much value in having your children take a break and go outside. What happens to outside, that whole thing of we get so caught up with the digital devices, we forget that other aspect of being able to be in nature, the value of that. Just being able to be outside in the sun, there's value in being the vitamin D that you get out there. That's natural. Because one of the things that we're certainly being advised to do during this pandemic is take vitamin D3. So it is important that you help to structure that environment for your children. And part of taking a break is being able to go ahead, go outside. Play is a healthy thing. It's a normal thing. We're still trying to, in the midst of this pandemic, we're trying to ensure that we have persons as normalized as possible. So if we can be able to balance work with play, and some of that play is now happening away from our digital devices, that'll be a good thing.
Thank you very much.
We have reached our third and final segment. My name is Kaywana Raming, and I'm pleased to introduce our speaker for this segment. We'll be learning all about innovative medical therapies. Our first speaker for this segment is Dr. Turan Aurora, who will present on advances in management pterygium. Dr. T. Aurora is consultant ophthalmologist and cornea specialist at the Princess Margaret Hospital. He completed his ophthalmology residency and subspecialty training in corneal lens and refractive surgery at Apex Institute. Dr. Regina Prasad Center for Ophthalmic Sciences, All India Institute of Medical Sciences, New Delhi, received the Achiever Award at 33rd Asia Pacific Academy of Ophthalmology Conference in 2018. He's the Best Resident Award at AIMS in 2016. Reviewer of numerous international journals in cornea, lens, and refractive surgery. I now present to you Dr. Turan Aurora.
Good day, everyone. Thank you for the kind introduction. Okay, 1 second, let's go to slides. So today I'll be talking about the advances in the management of pterygium. I'm a consultant at Princess Margaret Hospital and Bahamas Vision Center. Why I chose this topic is because pterygium is one of the very common diagnoses we see in our clinics in the Bahamas, because it's in a tropical area where a lot of sunlight exposure is there in different occupations. My objective in this presentation will be to discuss the various prevention of recurrence objectives, and then the surgical keys to management. What are the various role of adjuvants in treatment of pterygium? What are the fixation techniques, and what are the future, what course it looks like? So this is a classical picture of pterygium, and I'm pretty sure everybody of you must have encountered in your day-to-day clinical work as well. This is when a membrane from the conjunctiva, basically it extends onto the cornea. It could be of various sizes and dimensions, various thickness, vascularity, but when it crosses this limbus, or it's just beginning at the limbus, this is when we make it a diagnosis of pterygium. Now, why do we need to remove it, or what are the indications of removal? The primary indication of removal is when it starts to encroach the pupil. As you see in this image over here, this is a little larger pterygium. We sometimes see very smaller pterygiums as well. But if it starts encroaching on the pupil, it might block the vision for the patient, and is one of the main causes or indications for removal. The second indication could be when it kind of stretches on the cornea and it causes against the rule astigmatism, like because of its fibrovascular nature, it will stretch on the cornea and it will cause a refractive error, and the patient's vision will drop because of that. The third indication would be when there is recurrent redness and inflammation in the pterygium, and it causes a lot of discomfort and dryness in the patient's eyes because of this it being an elevated lesion on the top ocular surface. And that would be another indication for its removal. And last but not the least, sometimes the patient cosmetically wants, even if it's small, they are not comfortable with the lesion and they would want it to be removed. So these are the four basically main indications of removal. As we discussed, pterygium, this is an uncontrolled fibrovascular tissue overgrowth of the conjunctiva that overlays the sclera and involves the corneal surface. So important term is a fibrovascular tissue. So it has both a fibrous component and a vascular component. Recently, a meta-analysis estimated the prevalence could be sometimes as high as 10% in the general population. And recurrence after pterygium is a major challenge. So that's why we are going to discuss what are the problems with this very small kind of a problem. It looks like you can just remove the membrane and get done with it. But we'll discuss why it's not so easy. So what is the definition of recurrence? It can be identified by episcleral vessels growing towards the limbus, leading to fibrous growth into the cornea. So it starts with the vessels and then also has some fibrous tissue involvement, and both of these extend onto the cornea. So this is a Senks criteria. It's a 4-point scale. If after doing a normal surgery, it looks like a normal appearance, is grade 1. If you just see those fine vessels going over to the limbus, it is classified as grade 2. If you start seeing a fibrovascular tissue extending as well, that will be a grade 3. And if you see a picture like you saw in the last slide, then it will be a grade 4, like it will be a true corneal recurrence, like a full fibrovascular tissue invading the cornea. What are these factors for recurrence? Why would a pterygium once removed would come back? The more common factors are age. So any younger population, the fibrovascular activity is much higher and they are more predisposed to recurrence. Race-wise, it has been studied that Hispanic and Black patients are more predisposed to a recurrence of pterygium. Third is morphology. So the degree to which the pterygiums were non-translucent, that means they had increased vascularity. So the more thick the pterygium, the more vascular it is, the more it is, you're not able to see the underlying sclera, the more chances of recurrence are there. Then the surgical technique. So this is an interesting thing, that the bare sclera, what do you mean by bare sclera is if you just remove this pterygium from the top, like if I just remove it and cut it, it will just leave a bare sclera underneath. There's 88% recurrence. So you can be assured that 9 out of 10 patients, if I do that, just that simple technique, would come back with a recurrence. So that it's not, you can't just simply remove it. And this was up till a time period in ophthalmology. This was the technique that was only done and we didn't know what to do more than that. And I'll discuss how additionally we started managing that and where we have reached today. It will be an interesting journey from there. So any improper surgical technique can lead to recurrence, and we'll discuss about that. Post-operatively, increased inflammation after surgery or dry eyes can again cause a lot of inflammatory milieu over there and can lead to the membrane growing back over the eye. So another factor for recurrence. And similarly, environmental factors like dryness and dusty environment, again UV exposure, can again cause this recurrence. So these are the common factors for recurrence. So what is our preferred technique? When that kind of pterygium comes to eye, what is our preferred technique? Is a conjunctival autograft. So this was described by Kenyon in 1985. And they reported a low recurrence rate of 5%. So you see from just one technique, the recurrence rate has come from 88% just to 5%. Subsequently, they did more studies and they saw that it's not exactly 5, but between 5 and 30%, like in different population groups and different, if you do not have the ideal patient, like if you have all kinds of patient and then you do it, the recurrence can be between 5 and 30%, like in these cases. What we exactly do is when we remove the pterygium, we take a graft from the top part of the conjunctiva. It's a thin graft, just the top part, and we move it towards the bare sclera. So we move that graft from the top towards the bare sclera so that it covers that bare sclera, that area. So that area is not laid bare. It is covered by an autograft. So the patient's own conjunctiva from the top is used to cover that area. Now it looks simple when I explain it, but it's technically demanding because you want that graft that has to be very precise. One is that the graft has to be very thin. It should not have that underlying tenons and all that fascia coming with it. Then you need to make sure that when you cut the graft, there should be no buttonholing in that. Like there should not be no holes in the graft or anything. So graft has to be taken very precisely, like very nicely in a very clean manner. If there is any rough edges or you cut in between, you make a hole, then then again, that area is bare for the sclera. And again, there could be inflammation and again, recurrence and all that things can come back. So this, it's technically demanding than just doing a bare sclera technique. Then if you have to close a large graft, so if a pterygium is very big, like if it's very big involving 3 to 4 clock hours, and if you remove it, then you need a very big graft. So it's not, so if the pterygium is big, and some patients come with both side pterygium, like a biheaded pterygium, like you see the pterygium coming from both sides, very aggressive. And if you have to take out both at the same time, which we normally have to do, there's not enough conjunctiva at the top to like move it to both sides, like nasally and temporally as well. So large defect closure is difficult with conjunctival autograft. And also if the patient in future might need a glaucoma filtering surgery, you don't want to touch the superior conjunctiva because then that conjunctiva helps in glaucoma filtering surgeries. So you want to leave that conjunctiva alone because that might be helpful for the patient. So any patient, and especially over here because glaucoma is also very common. So you have to be mindful of that when the patient has a pterygium and glaucoma, it's better to take the inferior conjunctiva rather than taking the superior conjunctiva and leaving that for in case a glaucoma surgery is required in the future. Another technique that was described was a limbal conjunctival autograft. So what they saw was because the conjunctival autograft in itself was causing a recurrence between 5 and 30%, it was observed that if we take a little of the corneal tissues as well, like a little limbal and peripheral corneal tissue, because that has some limbal stem cells. Now, what limbal stem cell does is it's very important in prevention of the conjunctiva going on to the cornea. It's like a barrier. So if we transplant those limbal stem cells along with the conjunctiva, the recurrence rate came down to even lower, between 0 to 15%. However, it doesn't remain a simple surgery as such. It is not required for every case. It is only required for multiple recurrent cases. So it requires, there was a study done which compared both the limbal and just the conjunctival autograft in both advanced and recurrent pterygium, and they observed that it is not required even in advanced pterygium. Only in case of recurrence, this might add to just doing a conjunctival autograft. So this is another technique which might be helpful in certain scenarios. So why is this recurrence? What are the patterns of recurrence? So I'll just briefly tell, if there is a bare area, then it can lead to this aggressive inflammatory type of recurrence, which is like the pattern 1. So if you supposedly put a graft and somehow the graft separates from the host conjunctiva, so the position is not good. So there is some bare area that will cause a lot of inflammation over there and lead to an aggressive inflammatory kind of a recurrence. Similarly, if you leave a buttonhole in the graft, there's a small hole in the graft which you made because of surgical dissection, there's a hole in the conjunctiva. Again, that will leave a small area of bare sclera. So anytime there's a bare sclera, that can lead to a lot of inflammation and aggressive recurrence. Other types are more slower when either because of the primary etiology, like why did it happen in the first case? There's a reason why it happened in the first case. It can again happen because of the same reason, because the patient again has UV exposure, dry eyes, dust, and all that. Again, that same changes can happen with the graft, and it can lead to a slower recurrence like that. Or third pattern is when we were not able to remove that initial pterygium properly. So we left some remnants of that fibrovascular tissue. And over time, that again kind of grew back and it again came onto the cornea, causing another recurrence. So these are the 3 patterns which we have to note down. Now I'll talk of some additional techniques which help us in prevention of these recurrences, and when these recurrences happen, how we deal with them. One of the important things is the role of amniotic membrane. So amniotic membrane is like an anti-inflammatory, anti-angiogenic, and neurotrophic, has effects because of various anti-inflammatory mediators it has. It is much less tedious and less time consuming because you now don't have to fashion a graft. You can just take an amniotic membrane. It comes in a prepared, and you just have to take the amniotic membrane, size it, cut it, and just paste it there. So it's much simpler, it's less tedious, less time consuming. It saves the conjunctiva, so you don't have to use a graft. There is no size limitation because you can make it as big as you want. So you can actually excise the tissue much better. You can excise more or part of the pterygium. So you're not worried about the transplantation because you don't have any limitation. However, the recurrence is between 6 and 40%. So it's a little higher recurrence than doing just a conjunctival autograft. So that is why this is not our go-to management. Our go-to management is still conjunctival autograft. But if there is like a biheaded pterygium, a very large pterygium, or where you cannot fashion the conjunctival graft because of you already fashioned it a few times and there's no conjunctiva, virgin conjunctiva over there, or there's because of glaucoma surgery has been done over there. So you then go to this amniotic membrane as your savior for that case. Yeah, it is actually. So when they compared conjunctival autograft to AMT in 4 studies, in one of the studies the recurrence was similar. However, the other studies, they saw that this conjunctival autograft had a lower risk of recurrence 6 months after surgery compared to AMG. And in case of recurrent pterygium, it was even lesser with conjunctival autograft recurrence. So definitely conjunctival autograft is our go-to management, and amniotic membrane is reserved for some special cases as we just discussed. Now there are also some hybrid techniques where you take both. So supposedly if you see this defect is very big and you're not able to fashion that big a conjunctival autograft. So what the authors did is took a conjunctival autograft right at the limbus, but surrounded it with amniotic membrane. So it you covered the whole space with amniotic membrane. So you did not need to take a big conjunctival graft, but then you combine both the techniques and they saw actually very good result. And like this study had only 1% recurrence rate after surgery. So the advantage of this technique is that you can, when you're cutting out the pterygium or you're dissecting the pterygium, you can dissect it properly. Like you are not worried that if I dissect too big, then I'll not have that big a graft to put, because you can cover the rest of the area with amniotic membrane. So a very good technique actually. Again, not required in every case. So we have to understand that amniotic membrane is not required in every case because the normal conjunctival graft has a very good results. Like we have very good results. Actually, it comes down to, if you do the technique properly, it does come down to like 5% recurrence, which is pretty good actually. So the surgical technique is the single most important factor to prevent recurrence. Like if whatever graft you use, but if your surgical technique is not good, if you don't understand the anatomy and have not dissected the original pterygium tissue properly, there's always will be a higher chance of recurrence. That is why that variation of 5 to 30% because of difference in the surgical techniques and other factors. So any inadequate peripheral dissection or irregular bed or insufficient graft size, thicker graft, or graft retraction because the fixation wasn't proper can lead to recurrence. Diamond burr, which we fortunately also have at PMH, is very helpful in removing the residual attachment. So we use it on the cornea and to smooth the corneal skull surface. So what it does is diamond burr, because it's a rotating burr, it will smoothen the surface very nicely. So it removes all the remnants. And then it's important to excise the underlying tenon's tissue from the conjunctiva. So that helps in completing the dissection. Always use a thin conjunctival graft. That is recommended because it prevents excessive chemosis and minimizes the scarring in the donor area. So a thin graft, how we do that is by using a spring action Westcott scissors through a small opening to dissect the conjunctival surface from the tenon's fascia. Then you have to handle the graft very properly. So if you use any tooth forceps or a sharp forceps, you can again create tear in the graft or make a buttonholes. So always we use a non-tooth forceps to pick up the graft, and we very gently we have to like move it to maintain the orientation as well. Another technique which was described was a perfect technique. It's a pterygium extended removal followed by extended conjunctival transplant. So this technique showed a recurrence of 0.1%, but it's a very lengthy technique. Like it can take between an hour to like more than that to do a pterygium surgery, but it involves excessive resection. Like excessively is basically removing anything around that pterygium and making a large graft and putting it there. So again, very good, less recurrence rate, but I don't find it ideal because it's like you're doing massive surgeries like just to remove a smaller thing. So in primary conditions, definitely not indicated. So how to manage a recurrent pterygium? So if you do a pterygium surgery and then you see a recurrence, how would we manage it? First, we wait for some months for the inflammation to subside, because inflammation is one of the key factors in causing the recurrence of pterygium. We want it to subside. We can give some anti-inflammatory agents for that. And when we are doing that surgery, we don't want to like resect too much. Again, we don't want to cut too much of conjunctiva. We just want to cut the pterygium part and let it recess, like let it go back, so we can just put a graft over there. We need to make sure that we seal the gap between the conjunctival edge and the underlying tenons. So the tenons does not come from below the conjunctiva. Important to even identify if you have to go like really, really large, we need to identify the muscle over there. We need to cover it with a AMG, make sure that it is properly protected. Now, certain adjuvants have been used for recurrence, and this is very interesting. So they saw that when mitomycin C and especially mitomycin C was used along with pterygium surgery for recurrent pterygium cases, it was very effective and much more effective than placebo for reducing the recurrence. If we have to use a drop, then cyclosporin eye drop is one of the very has been the only other medicine that has shown any effect in preventing the recurrences. Mitomycin C can be used in various forms. It can be used preoperatively, it can be used intraoperatively, it can be used postoperatively, but the most commonly used is intraoperatively. So whenever we see a patient coming with recurrence of pterygium, if you're doing the surgery again, along with the conjunctival graft, we'll always like to use mitomycin C as well. And the most commonly done is like an intraoperative technique where when we dissect the pterygium, we apply mitomycin C just at the edge of the conjunctival, between the conjunctival edge and the underlying tenon's capsule. There can be, however, complications of mitomycin C. Therefore, we do not like advise it for a primary case. Like if you see a primary pterygium coming first time, we would not do a mitomycin C in those cases, because the mitomycin C is, as you all know, it's a toxic drug even to the eye. It can cause long-term problems like glaucoma, scleral calcification, infections, scleral melting, perforations, edema, iritis, and ophthalmitis. So there's always a chance of penetration of that mitomycin C inside. And believe it or not, a corneal scleral melt has been reported 50 years after resection of pterygium along with mitomycin C. So you can imagine, like even like it's, after 50 years, there's a case report that there was a melt after doing this surgery. Bevacizumab, that is popularly known as Avastin, has been tried as in various forms for management of pterygium. So it's anti-VEGF. So basically its role is to decrease the vascularity. However, as we discussed, pterygium is not just a vascular structure, it's a fibrovascular structure. So this doesn't do anything to the fibrous component, only does decrease the vascularity a little bit, but does not have any role in preventing basically or preventing recurrences or has any management role in recurrent pterygiums. However, I mean, it's an evolving field, and we will see. As time goes, we'll see how if it can play any role in its management. Cyclosporin A has still shown some role in topical form when used after surgery and decreased recurrences as compared if you compare to a base clear technique and you do it along with cyclosporin, the recurrences were half. So it definitely helps. So in any case which is high risk, you can always use cyclosporin. It decreases that inflammation on the ocular surface and helps in healing and prevention of recurrences. So whenever you want to apply any adjuvant like mitomycin C, cyclosporin, or anything like that, we have to see the risk-benefit ratio. What are you gaining from that, and what can you lose from that? So I never like to use mitomycin C in my primary cases. I do a simple conjunctival autograft because that gives me the maximum benefit and the lowest risk profile. However, if there are recurrent regions that are coming to us, we always want to use mitomycin C in addition to our primary, especially if we know that the surgical technique and everything, we did it ourselves and we are pretty sure that it was done very well. Still there was a recurrence, and we want to apply mitomycin C in the next go to make sure it doesn't happen again. I think this is the last probably topic in the management of recurrent pterygium is how to fix these grafts. So initially, suturing was the only technique which was being used for a long time. We used to use vital sutures to like suture all end of the graft to the host conjunctiva. However, suture has several disadvantages, including prolonged operative times, a lot of patient discomfort in post-op. They will feel the suture, they will be very uncomfortable. And any kind of discomfort also causes inflammation. And inflammation causes recurrence. So all these are very related. So then the next thing that came was a fibrin glue. Fibrin glue is a glue that is used to kind of attach this graft over to the host cus clara. And they saw the recurrence rate after fibrin glue was found to be less compared with sutures. But there was no significant difference with the use of autologous blood coagulum. So when I came here, we're doing a suture technique, and then right at that time, fibrin glue was already being used from long time, but some of the recent studies, I mean in 2018, at that time started showing that even you can use the patient's own blood, because as we all know, the blood clots, and it can basically fix, like when there's bleeding, it clots and it stops the bleeding, so it acts like an adhesive. So right at that time, because the fibrin glue is expensive and not like widely available. So when I came here and the same time these studies were coming that we can use fibrin like blood instead of fibrin glue, and they have the same recurrence rate. So no difference in recurrence rate. So we started using autologous blood coagulum right from that time, and I haven't looked back. Like there hasn't been any case in which we have used sutures ever after that. All cases we use are like autologous blood coagulum. The only important thing in using that is that when you do the surgery, and some of you might have assisted me doing that, is when you attach the graft, you have to wait for some time to make sure the graft is well attached and it's not moving. And sometimes I would even remove the speculum, stay there, ask patient to blink like 5-10 times, make sure that his eye blinking doesn't move the graft. Also make sure that there is no, like when you use the autologous blood, that it's very thin, like, so it's not like kind of getting detached. And we have got excellent results with that. The patients are very comfortable. It decreases the same recurrence rate. Only thing we have to look in the next follow-ups is the graft stability. We have to make sure that the graft stays there. Like, so we have to keep a special attention to that, because the studies also say the fibrin glue has the best graft stability though. But fibrin glue is pretty expensive. It's not widely available. This is an excellent alternative, and we are making like full use of this. Post-operative inflammation have to be controlled. We can use steroids, we can use NSAIDs, we can use cyclosporin A, depending on how much the inflammatory milieu is, and use artificial tears to give proper lubrication, and that should be fine. So what are the future direction? Like future directions would be to basically have some kind of a like modeling to know, like based on the thickness of the pterygium, the size of the pterygium, what is the best, like out of all that what we talked today, what would be the like perfect modality for that? Like should we just use CAG? You should how to predict like in which cases like mitomycin C initially would only help. Like suppose all the primary cases we're just doing conjunctival autograft. So can I have some indicators like which cases I should definitely use mitomycin C and which cases like, so that modeling has to be better, and we might need some additional tools like biomarkers, inflammatory mediators to kind of help us give that path. So my take-home message is a good surgical technique is the most important factor. A conjunctival autograft is the most effective and safest procedure for preventing recurrences. AMG plays important role, but in specific scenarios, adjuvant administration should be done keeping the benefit-risk ratio in mind. Fibrin glue lowers the recurrence rate, also provides good graft stability. So fibrin glue is definitely the best out of all fixation techniques. And managing the postoperative inflammation is the key to preventing recurrences. And that will be it. Thank you so much. Yeah, no, so I haven't seen any case like that with the graft. Sometimes really what happens is if the attachment is not very good, you might see a small gap between the graft and the host. So the graft still stays there, but you might see a very small gap, like the attachment might just go around a little bit. In those cases, you have to even like increase the steroids and everything just to make sure the inflammation is very low. So only, I mean, you don't, it can happen. It can happen for sure where the full graft can like go off. But I haven't seen that, but we do see very rarely sometimes that graft might just kind of not be very well opposed in certain cases. And then we have to kind of monitor them more closely and increase the steroids in those certain scenarios.
First, the use of the blood during the surgery, in order to coagulate for the patient, that is totally magical to me. So that's awesome. So being present to see something like that is awesome. Now, what I want to know is, I know that in the best interest of the patient, you'll be planning to say what is the best strategy to use for the patient. But do you have special requests? Let's say persons who maybe. Okay, testing 1, 2. Okay. So, like I said, the first part of my first comment was saying that the blood is actually, to me, magical to be able to use the person's own blood to coagulate and keep the graft together. But my comment is, does the patient itself have any say into the type of strategy they would want to use? Let's say persons who have preference for religious reasons. Let's say, I guess not in the Bahamas, but maybe elsewhere, you may have practice. Who may say, okay, I don't want to use amniotic membrane, different things like that, because it may be against my religion. Do persons Google enough to know the science behind it to say, I don't want this, or I prefer to have that?
Yeah, so I mean, we explain the procedure to the patient, and it's, I mean, if patient has any objections, they would definitely let us know. But I haven't like come across a patient who has had any objections thus far. But yeah, if the patient has objections, we have to give them the alternate strategies. That's for sure. But the blood over here, another interesting thing, sometimes people think that it's the blood we take from the veins. But it's the same blood, it's on the surgical side. So we're not taking any blood from the veins or anything like that. It's the same blood as the surgical side we're using for coagulation. Can you give the mic,
Okay. Okay. The surgeries that you have done, have you had any reoccurrences?
Yes.
And what's your percentage?
Yeah, percentage will be around 5 to 10% actually. It is there because the reason being, again, it's a tropical environment. A lot of people, their occupation is like they're fishermen or they're working in those sea waters and all those places, especially in the more younger population. The recurrence, you cannot avoid it altogether. If somebody says they have had no recurrences, that must be some kind of a magic they must be doing. Because it does happen, and especially in younger population, whose occupation is right in the sun and working in those waters. I tell them that, I will do it, but you'll have to take special precautions because we have special these UV-rays protecting glasses.
Yes, that's what I was going to ask you. Since you have had reoccurrences, and even before reoccurrences, do you really see the effectiveness of the UV rays glasses? Does it really, really work? And if it does, at what percentage? Because I would honestly say more than 80% of the population in the Bahamas, I would say, don't normally wear sunglasses, even though we're a tropical climate area. we don't endorse that so much on a regular day. So how effective would you say to using the sunglasses?
It's very effective. The glasses normally that UV protection is, the number should be more than 400, UV 400. That prevents more than 99%, 99.9% of the UV rays from coming to the eye. Not only pterygium, if you see the general population over here, you will see a lot of pingicula, the elevation on the cornea, on the conjunctiva. You will see a lot of cortical cataract. The most common cataract over here is cortical cataract. All these problems are all because of UV, like they have been directly connection with the UV rays that are going to the eye. So definitely I myself wear it all the time when I'm outside. And I recommend to any patient who comes with even a small, like a pingicula or a pterygium, I tell them very categorically that, see, this is going to increase if you don't like protect your eyes from sunglasses. Not everybody, I mean, does get affected. That's also a truth. So whoever is not affected does not take the advice that seriously. But if I see anybody even has any start, like, and you will see a lot of cataracts. More than 80% of cataracts that come to us have cortical cataract. Cortical cataract is one of the type of cataracts is most common because of long-term sun rays exposure, as compared to other kinds of cataracts which we see. So it's a very direct evidence that it is there. And I mean, we do tell patients very, I mean, on a very serious note, like to wear, I mean, protect their eyes from sun rays.
So can we prevent pterygium from developing, and what can we as a population do to prevent it if it can be?
So see, any disease like, and pterygium is one of them, they're all multifactorial. Like there is no one way, just if you don't just stay at home, then you'll never get it. Like as we discussed, there are tens of reasons why it can happen. Like it could be because of dry eyes. It could be, pterygium could also be, I mean, sometimes there could be limbal stem cell damage because of some kind of inflammation going on the eye. So they're multifactorial. What we can do is like decrease the factors, like decrease the chances of it happening, or decrease those factors. So that helps in the prevention, but there is no 100% like way to like prevent anything like.
Okay, thank you.
So yeah, so stage, as I discussed, there are precise. Okay. So the question is what? Okay, I think you can repeat the question.
At what stage do you remove the pterygium?
Yeah, so as I discussed in the initial slide, and when I showed the picture, there are some specific indications for removal of pterygium. It's not about the stage. Sometimes even a bigger one like could be left, but sometimes even a smaller one has to be removed. And I'll just repeat very quickly again, is one is if it is encroaching on the pupil, like you saw in that picture, because it's going to obstruct the vision absolutely, like it's very like right on the axis. Second is even if it is small, if it is pulling the cornea, and you will see that in the astigmatism, the patient's glasses get changed, the number has changed, the vision has gone down. So even a smaller one that's pulling on the cornea, and you will know when you do the keratometry, has to be removed. The third is when it is causing recurrent inflammation, like even if a small one is there and it's causing this recurrent inflammation, recurrent redness, recurrent kind of that inflammatory thing on the eye, and it does bother the patient in their day-to-day work, that's a clear-cut indication of removal. And sometimes even if it's small, patients they mentally get really affected by it because it's cosmetically. People tell and come to them and tell them that, oh, you got what's on your eye, and they just don't like that thing, so they just come for that cosmetic indication as well. And that's a fair enough indication because it plays with their mind, but you have to again explain them everything, explain them that about the chance of recurrence and how you're going to do it and everything. But that's indication as well.
Is surgical intervention the only means of treatment of pterygium?
Yeah, so that's the only way. That's why we discussed about some of the other ways they try to do it, like because it's a fibrovascular growth has already happened. Either if you don't do anything, sometimes it can just regress. That's why I'm saying if it's not indicated, you can just wait and watch. Even if it regresses, it just leaves a small scar or it's called atrophic pterygium. Like it just gets atrophied, like the fibrous component goes down, the vascular component goes down. You might still see it, like if you look at it closely, but it's not that bothersome to the patient or to the otherwise. So the patient might just not get anything done with it. But there is no way like you can totally get it like cleared without any surgical management. Yeah, so the laser has no role of laser in this management of pterygium as such. I mean, there have been some very interesting studies where they cut the graft with the laser, with femtosecond laser and all that. It's those fancy things at fancy institutes, but in like real way, it doesn't help much basically.
Hello? Yes, that's an excellent question, Sister Russell. I've had patients come to me and say, I would like to get my pterygium taken off by laser. And I'm like, well, that's not something that we can offer you. And even if it was something that we offer, I'm not so sure what the results are. So it is available, though, I have to tell you. I have patients that say, I have a doctor in the States, in Florida, who does it. Now, what the outcome is, I'm not so sure on what other treatments they add with it, but it's interesting that, yeah, we have patients locally that are aware that this femtosecond laser can be used, and they are going for it.
It's a study from Singapore. They came out with that, and basically these newer femtosecond lasers they have tried in almost all the pathologies that they can be dealt with, and pterygium is one of them. They tried to create the graft, the top graft, with the laser rather than like doing it surgically. Again, the study showed equivalence, like it's equivalent to that, but I don't think there's any added advantage. But we'll see. Those things also keep improving with time, and you never know. How things go in future. Because those lasers also keep advancing, and if there's something it does get better result, then we'll know about that. That's why I took the topic. Yes, I know that. It's very fascinating. Yeah.
Since you came back, since you were doing them over here, you use the sutures, right? Have you ever used sutures?
So basically, when I started my training, my ophthalmology training, I used to use sutures in the first year, and then I always use fibrin glue. When I came, because that's the best. Fibrin glue was the best. But then when I came here, we started doing sutures because there was no fibrin glue. However, right at that time, these studies started coming where they showed that blood is same as fibrin glue in its results and everything, and comfort and everything. So then we tried it because it was already published. 3-4 studies came out and they published that it's very it was being talked about in the conferences and everywhere. So we thought it's worth giving a shot, and because the studies are already published, so it's safe and everything. And once we tried it, there was no looking back. I haven't done suture. No. After that, I did first few cases, 3-4 cases over here with suture, and then never after that.
One more question. Is it possible that acid, let's say acid from a car battery, being placed into eye accidentally cause pterygium growth? Yes. Can it do that?
Yes. So that's basically the terminology for that. What we call is a pseudopterygium. Like if we know the cause, like an acid injury, the pterygium that causes. We have to differentiate. There could be if it's just a limbus stem cell damage, it could be a pterygium in long term. But if it's a growth right there, it is basically classified as pseudopterygium. So we sometimes have to differentiate between them. But yes, basic concept is similar, that it causes those limbus stem cell damage at one side, causes that conjunctiva to grow from there over the cornea. And yes, it's one of the pterygiums. Yes. Okay. Yes, the classification is a little different, but exactly it's the same thing. Etiology is again same. So limbus stem cell damage, because of any etiology it happens, all of them basically allow the conjunctiva to grow on the cornea. Okay. So yes. Thank you so much. Thanks a lot.
Thank you, Dr. T. Aurora, for that informative presentation. Our next speaker is Dr. Salvador Tinio Jr. on recognizing strabismus. Dr. Tinio is a senior registrar in the Division of Ophthalmology. He obtained his Doctor of Medicine degree at the University of Santo Tomas in Manila, Philippines. He's also been a staff consultant at Quirino Memorial Medical Center, Philippines, and the Department of Health in Quezon City, Philippines. Chief resident at Quirino Memorial Medical Center and member of the American Academy of Ophthalmology. At this time, we want to present to you Dr. Tinio.
Okay. Good afternoon. My name is Dr. Tenio, and I'm going to present a case of strabismus here. First, there's no financial interest to discuss, and let's start. Okay. The Latin word for strabismus is derived from a Greek word strabismos, which means squinting. Sometimes it is also referred to as squinting eyes or crossed eyes. Strabismus is a condition in which the visual axes of the eyes are not parallel and the eyes appear to be looking in different directions. A disorder of ocular alignment characterized by a horizontal, vertical, and or a torsional deviation of one eye relative to the other eye. Strabismus is one of the most common eye conditions affecting around 4% of our population. In a study of children aged 6 to 71 months of age in Baltimore, Maryland, showed a manifest strabismus found in 3.3% of white children and 2.1% of African American children. U.S. national population projections suggest that there are approximately 677,000 cases of manifest strabismus among children 6 to 71 months of age. New onset adult strabismus showed the incidence rate of 54.1 case per 100,000 adults, and the peak incidence for adults is in the 8th decade of life. Estimated life risk expectancy is 4.0%. For social implication studies, children aged 5 years and older expressed a negative feeling about dolls that have been altered to be esotropic or exotropic. A study showed elementary school teachers rated personal characteristics of children with strabismus more negatively than orthotropic children or children with straight eyes. Visible strabismus negatively influences individuals' ability to find a job and therefore has an impact on their economic status. Strabismus creates a significant negative social prejudice. These biases can be a detrimental impact on socialization and employability. The presence of strabismus adversely affects lives, including finding a partner, job prospects, interaction with peers, and sometimes manifest as psychiatric disorders. Okay. For the rationale of treatment, the potential benefit of treatment includes promoting binocular vision and normal visual function on both eyes. Fusion and stereopsis are necessary for some careers and useful in many activities such as driving a vehicle, athletics, and activities of daily life. Binocular alignment is important for the development of a positive self-image. It enhances social interactions by normalizing appearance as well as eye contact. Okay. We describe strabismus by the deviating eye as to its direction. It could be looking inward or towards the nose or esotropia. It could be outward or exotropia, looking out. It could be upward or hypertropia. It could be downward looking or hypotropia. Okay. There's 3 classifications for strabismus. First one is apparent or pseudostrabismus or false strabismus. The next is latent strabismus or heterophoria or the tendency of the eye to deviate. The last one is manifest strabismus, heterotropia, or we call tropia. This is the obvious eye misalignment. It could be comitant or there all the time. It could be concomitant, there once in a while or sometimes. Pseudostrabismus is the false appearance of crossed eyes. We usually see this in infants and young kids with prominent uh, epicanthal folds, the one in the middle part, the lids on the middle part. Okay. There is also pseudostrabismus in adults, and usually we see them among Asian populations. Latent strabismus, heterophoria, or phoria is a tendency of the eyes to deviate. Misalignment only appears when binocular viewing is broken and the two eyes are no longer looking at the same object. They usually don't disrupt everyday life and can occasionally cause eye strains and headaches. Manifest strabismus, heterotropia, or tropia is eye misalignments that are readily apparent, evident, and obvious. Okay. Strabismus can also be congenital or infantile, appearing at ages of less than 6 months, or it can be acquired later on in life. Acquired strabismus can be a result of an accident such as a trauma or other health problems like a stroke or diabetes. The eye deviation can be there always present or comitant. It could be intermittent or concomitant. Sometimes when patients are fatigued, there's visual inattention, or sometimes if there's illness. The most common strabismus presentation we see in the clinics are esotropia or crossed eye and exotropia, or when the eye is looking to the side. Okay. Most eye deviations are caused by the brain signals that control the excessive movement of eye muscle towards a certain direction. The actual problem with the eye muscles and orbital structure causing the strabismus is rare. Early diagnosis is essential in preventing vision loss that occurs as amblyopia or the development of a lazy eye. Amblyopia occurs when the vision does not develop normally during childhood because the eyes are not aligned. Amblyopia or lazy eye occur in up to 50% of young children with strabismus. Strabismus often occurs in children who are otherwise completely normal. Disorders that affect the brain, such as cerebral palsy, Down syndrome, hydrocephalus, and brain tumors are high risk in developing strabismus. Adult eye misalignments are either from a residual childhood strabismus or are newly acquired in adulthood. Causes of acquired strabismus could be paralytic, like strokes, traumatic brain injuries, diabetes, or it could be restrictive, like orbital masses and trauma. The most common cause for adults is a stroke or a neurological problem, vascular problems like diabetes and high blood pressure, and trauma. Trauma can cause strabismus by brain damage that impairs the control of the eye movement, or the damage of the brains, the damage of the nerves that control the eye movement from the brain going towards the eye, or it could be damage on the eye muscles directly. Strabismus present since childhood, there is usually no doubling of vision. Misalignment in adulthood will almost always complain of double vision. To examine a patient with strabismus, we need a thorough history. We need to get the demographic data, gender, date of birth, and identity of the parent and caregivers, especially for children. Documentation of identity and relationship of the historians, again for children, and identity of other pertinent healthcare providers like pediatricians and neurologists that they have seen. The chief complaint or the reason for the eye evaluation should be noted. The date of onset, the frequency of ocular misalignments, which eyes are deviated and to what direction, the presence or absence of doubling of vision, closing of one eye, head tilting, and other visual symptoms are very important. Reviews of old photographs are helpful. For the ocular history, it should include other eye problems, injuries, diseases, surgery, and treatments, including the use of eyeglasses and or if the patient had amblyopia treatment. Birth weight, gestational age, prenatal and perinatal history that may be permanent, especially for children, are to be noted. Reviews of system and relevant systemic disease, current medications and allergies, the family history, especially if they include eye conditions, social histories, learning difficulties, behavioral problems, or issues with social interaction. To examine the patient, again, we need to do a complete eye examination. Okay, we need to do a visual acuity as well as pinhole eye exam. We need to do a strabismus examination, stereopsis test. We look at the eye alignment. We test the intraocular muscles. We try to detect if there's nystagmus or uncontrolled eye movements. The eyeglass measurement should be taken, and the fundoscopy or the retina examination should be done. Okay. We will discuss 5 tests for manifest strabismus. The Bruckner's, the cover-uncover, alternate cover test, Hirschberg's, Krimsky's, and the prism cover test. Okay. The first is the Bruckner's test. It's a general screening test for strabismus, mediopasities, abnormal pupillary reaction, and retinal anomalies near the visual axis. The advantage of this test is it takes only seconds to do. It's non-threatening to children, does not require close proximity, and can be done even with minimal patient cooperation. With this, we use an ophthalmoscope. We straddle the eye with the light. We straddle both eyes with the light from a distance of more than 2 feet. Any asymmetry or abnormality of the brightness of the red-orange reflex, if there's any changes in the color or of the reflex, it could be suspicious. Okay, so this is a patient. When we straddle the eye, both eyes with the light from the ophthalmoscope, we could see that the right eye has no red-orange reflex. The left eye has a good red-orange reflex. Okay, so the Bruckner's test is a general screening for the presence of eye pathology. It's not specific for strabismus. Okay, the next test is the cover-uncover test. The examiner alternately covers and uncovers one eye while being told to fixate on a distant target. Covering and uncovering of the eyes are performed several times, and we analyze positioning and repositioning of the eyes. In orthotropia or patients with straight eyes, there will be no movement, no adjustment movements, because both eyes are fixated on the same target. Manifest strabismus, when fixating eye is covered, the other eye moves to take up fixation. This test is very sensitive. It can reveal even small deviations. So the cover and uncover test, we cover one eye, then remove it. In B, we could see that when the eye was covered, the left eye started to take the position. It moved to take the position to see the object it's looking at. And after removing the cover, both eyes went back to their original position. The alternate cover test is designed to break the fusion of the eyes. We switch the cover from one eye to the other eye back and forth. It can be used to assess both manifest tropias and latent tropias, or the tendency of the eyes to drift. We cover one eye, then the other eye, and repeat this a few times. Okay. So both eyes are observed again for movement. When we cover one eye, then we cover the other eye, we monitor the movement of the eyes. Again, if the patient has straight eyes, there would be no movement. The next is Hirschberg's test, or the corneal light reflex decentration test. We measure the corneal light reflex from the center of the cornea, and from there we try to measure if it's deviated 1 millimeter, 2 millimeters, or is the corneal reflex in the middle of the iris and not in the center, or is it in the corneal limbus, not in the center. From there, we determine the appropriate size of the squint. This test is fast and this is simple. So in this patient, we shine the light while the patient is looking at a distant object. We shine the light in the middle and look at the reflection of that light in the middle of the cornea. In this patient, as the arrow is pointing at, the light reflex is right there at the center of the cornea. Okay. In this patient, the corneal light reflex is at the center of both eyes. We see also that this patient has a prominent epicanthal fold. This is a case of a pseudostrabismus, and this is false strabismus. Okay. In this patient, the corneal light reflex is in the center of both eyes. So again, no strabismus. Now, the corneal light reflex on this patient, the center is on the right eye, and on the left eye, it's deviated laterally around 2 millimeters on the left eye. This is a case of an esotropia of the left eye. In this patient, the corneal light reflex on the right eye is at the center. On the left eye, there is a deviation of around 4 millimeters laterally on the left eye. And this is a case of a patient with esotropia of the left eye. Now, in this patient, the corneal light reflex on the right eye is on the center. On the left eye, it is deviated medially 1 millimeter to the left on the left eye. This is a patient of an exotropia. The left eye is looking outside towards the side. Okay. In this patient, the corneal light reflex of the right eye is deviated inferiorly 2 millimeters. Okay. And the other eye, the left eye, the corneal light reflex is in the center. As we could see, this is a patient with hypertropia of the right eye. The Krimsky test gives us an accurate measurement as well as the direction and magnitude of the deviation. We put in prism lenses and we place it in front of the fixating eye. Okay. The prism are triangular lenses that bend light towards its base. So the light hitting the prism on one side, the prism would not direct it straight. The prism would direct the light angled towards its base. These are examples of free prism lenses of different measures and diopters, different thickness. This is you usually come in sets. So this is a prism lens set. Okay. So in the Krimsky test, it is the application of a prism to center the corneal light reflex. In the first right eye we have here, you could see the corneal light reflex on the side. It's decentered. Once we place in an appropriate prism in front of the right eye, you could see that the corneal light reflex was then centered to the center of the right eye. Okay. Now, prism cover test is a combination of the other tests we discussed. The tropia or the deviation is first neutralized with the prism of the correct power. Then we use the alternate cover test. If we could use the correct prism power, if we do the alternate cover test on both eyes, there should be no eye movement. That shows us, if there's no eye movement, that we have placed the correct prism power in front of the eye. Now, the goal of treatment for strabismus is to improve eye alignment, which allows for the eyes to better work together and to have binocular vision. Treatment includes the correction of refractive errors with the use of eyeglasses, the use of prism lenses with eyeglasses, treatment of amblyopia if needed, specialized exercises to regain the coordination of both eyes, and extraocular muscle surgery. For the correction of the refractive error, eyeglasses are generally prescribed. Children of less than 2 years of age are usually given eyeglasses if their eye measurement is plus 2 diopters or more. If the children are more than 2 years old, if there's a refraction of plus 1.5 diopters or more, we give them eyeglasses. We could also use in some patients the addition of prisms to the eyeglasses, which may benefit in promoting binocular vision. Large prism eyeglasses correction may be uncomfortable, heavy, and can cause distortion of vision. To decrease the dependence on prism glasses, surgery can be offered. Prior to surgery, other eye problems associated with the strabismus are usually treated first. Amblyopia, lidptosis, cataract surgery should be taken care of first. Surgery should be performed only when more conservative methods have failed or are unlikely to be of benefit. Eye alignment surgeries are performed for better appearance and to treat the disabling doubling of vision. Surgery can often improve the doubling of vision, depth perception, and increase field peripheral vision. Surgery is rarely justified when the primary objective is to just eliminate eyeglasses. Deviations of more than 12 prism diopters are usually considered for surgery. For us to do surgery, we need to know the extraocular muscles, and there are 6 of them, and their location in the globe, especially where they're inserted. This is the side view of the extraocular muscles. The basic principles of strabismus surgeries is recession and resection. Recession weakens the eye muscles. If we remove the muscles from the insertion site and then suture it nearer the origin to weaken the muscle. For resection or strengthening the muscle, we cut the muscles, making it shorter. For esotropia, we have a patient with esotropia on the left eye. What we plan to do is to weaken the medial rectus muscle of the left eye, and we would strengthen the lateral rectus of the left eye in order to make the eye straight, make the eye look straight. For exotropia of the left eye, we plan to do a resection or strengthening of the medial rectus of the left eye, and we would weaken or recess the lateral rectus of the left eye in order to keep the eye looking straight. Okay. First, we need to know where we would be cutting, the incision site. We would be exposing the muscles. We would be putting sutures on the muscles. We would be cutting the muscles from the insertion site, especially for recession, we would be weakening it. From that insertion site, we would move it back, weakening the muscles. For resection or strengthening the muscles, we would be cutting a piece of the eye muscle. Then we would suture that muscle which has been cut already and shortened into the same insertion site. Okay. Shortened muscle, stronger pull. Okay. This is that isolation of an eye muscle. Okay. Then we would be putting in sutures before we cut them. So we cut them next. And this is the eye muscle when it's already cut and the globe is it's freely moving. Okay. Then we suture the muscle back. Okay. Now, for complications of strabismus surgery, first is muscle loss. This could happen when there is suture slippage or breakage. So we should be using good sutures. There could also be muscle tearing. Okay, and the solution for it is good muscle isolation and good muscle visualization before we start cutting things. Okay. Another complication is eyeball perforation. Okay. In order for us to do this safely, we need to know the scleral thickness. The anterior sclera is 0.8 of a millimeter. The posterior sclera is 1 millimeter. In the equator between them, it is around 0.3 of a millimeter. Where we would be working at is around the equator. So the thickness of the sclera there is around 0.3 of a millimeter. And our sutures should be placed angled, putting it in at 45 degrees to prevent perforation. Another complication is hemorrhage. To prevent this and to manage this, we evacuate the blood and we do a good eye patching after surgery. Strabismus surgery is done under general anesthesia. Most people are back to their full activity in a few days. Most common complaints are headaches, pulling sensations with the movement of the eyes, foreign body sensations, especially before the sutures dissolve, and this could be lasting a few days. There is usually mild lid swelling, and the eyes are often red for a few days. Most individuals have significant improvement in eye alignment with one surgery. Occasionally, the surgery is only partially successful, and changes in eye alignment may change over time. For the success rate of the strabismus surgery, the deviation is usually decreased to less than 10 prism diopters in 88.6% of the time. Stereo acuity is regained in 62.9%, and satisfaction is running around at 85.7%. Additional surgery may be indicated on average in 10 to 20% depending on the age and the type of strabismus. Residual double vision after surgery may be treated with the use of prism glasses. Then follow-up is essential. Children remain at high risk for developing amblyopia and recurrences of strabismus. Recurrences that are not responsive to eyeglasses, patching, or medical treatment may indicate the need for repeat surgery. Eye professionals should discuss the findings of the evaluation, diagnosis, treatment, especially the expectations with the patient and the family. Strabismus, especially for children, is a long-term problem. It requires commitment from the patient and caregivers. The patient who adheres to treatment recommendations generally have better treatment outcomes. Thank you very much. Thank you. Okay, if there's any questions, be happy to answer.
Hi, excellent presentation.
Thank you.
I think I understand clearly everything that you said. Okay. Now about pseudo strabismus, you said in the presentation they really present with babies, kids.
Yes.
And when you assess the patient, do you use all of those tests for pseudo strabismus, or you just can tell off the top if it's pseudo?
Okay, good question. Usually we would do the corneal light reflex test, we would shine the light in front of the patient from a distance to light up both eyes at the same time. Usually, we could see when the corneal light reflex are right there in the center, they usually are working together. The eyes are working together. With pseudo strabismus, we could note that the middle part of the lids, they're usually a little thicker. Sometimes as the babies grow older or the children grows older, as the nose gets longer, it pulls the middle part of the lids there, making it look a lot better. Okay. But you just gotta be, there's also adults that have this. It's not strabismus. Their eyes are looking straight, they're aligned. But sometimes they have just, thick eyelids right there in the center. Okay.
You're saying eventually after. Oh, sorry. I'm sorry. You're saying that eventually, as the child grows and the nose extends,
Yes.
yeah, it will
It
correct itself.
Yes.
It will bring the
Yes.
everything to the
It
center.
pulls the skin.
Okay.
Okay.
Thank you.
You're welcome.
That was one of my concerns because when we looked at the slide showing the fold inside the eyelid
Yes.
on the child, and so that actually is not strabismus.
Yes.
It's just the person can't see straight because some lay person may be thinking, oh, this child has strabismus, and then I guess they can't diagnose the child because they're not ophthalmologists or optometrists or anything. But I have another question. You mentioned that some persons could acquire strabismus.
Yes.
And you mentioned also psychiatric conditions, things like that. I know it may be the misconception that persons may be born with strabismus rather than acquiring it. So in the Bahamas, in your experience, do you see many persons with acquired strabismus rather than persons who got it from, I guess, from birth, from in childhood or whatever, but actually in adulthood?
Okay. Now let's deal with the first one first. The pseudostrabismus, they have no strabismus. Their eyes are working straight. They just look like they have strabismus. So it's false strabismus. Their eyes working, coordinating together good. Okay. Next, we see a lot of patients here, especially if the patient had stroke, had trauma, when the patient got hit with something, sometimes when they're broken bones, there's sometimes if there's muscle entrapment there or there's a mass growing, let's say there's a cancer in the back of the orbits, this could give a problem to the eye movement. Sometimes we could see this as strabismus. We have a lot of patients here, especially patients. We have a lot of diabetes. We have a lot of patients with strokes. We see a lot of them. You're welcome. Okay. Thank you very much. Okay. Okay.
Good afternoon. Continuing with our final speakers for the afternoon, we have coming to us Mrs. Tamara Donaldson, and she's going to speak on knowledge awareness, attitude, and self-care practices with age-related eye diseases at the Princess Margaret Hospital and Sandilands Rehabilitation Center on New Providence. Mrs. Tamara Donaldson is a registered nurse practicing for the past 19 years, a certified emergency nurse and ophthalmic nurse specialist, worked in critical care nursing, HIV, STI education, Caribbean Regional Field Epidemiology certification, President, Bahamas Society of Ophthalmic Nurses, First Responder 2019 Hurricane Doreen, MOH COVID-19 team member, motivational speaker, first aid instructor, Bahamas Red Cross Society volunteer, a dedicated Christian wife, mother of 3. Mrs. Donaldson, receive her as she comes.
Good afternoon, everyone. And also happy Thanksgiving. It's a pleasure to be here. This research that was done during the ophthalmic nursing class in a very tough course, but it was a group presentation. And so I find it very interesting, of course. And my colleagues are listening in, so good afternoon and happy Thanksgiving to all of you. Okay. The World Health Organization estimates that 253 million people live with vision impairment, 36 million are blind, and 217 million have moderate to severe vision impairment. Wow. The major global causes for moderate to severe vision impairment are 53% uncorrected refractive errors, 25% unoperated cataract, 4% age-related macular degeneration, 2% glaucoma, and 1% diabetic retinopathy. The age-related eye conditions, which are cataract, age-related macular degeneration, diabetic retinopathy, and glaucoma, collectively contribute to about 32% to this problem. And this was back in 2018 when we did the study. So looking at our local facts here, we have the National Prescription Drug Plan. So this is just a little background so you would understand the study as I go forth. It provides about 9 anti-glaucoma medications for patients here in the Bahamas. And they spend about over $112,000 just for the glaucoma. Look at that whopping figure. That's the amount of a house. I'm purchasing a house. Diabetic retinopathy and cataract are not covered by this plan, by the way. So in this study, the researchers all agreed among the 4 of us that the 2 government hospitals are the major gatekeepers of health. The study seeks to examine the knowledge, awareness, attitude, and self-care practices of age-related eye disorders that would soon and has already probably impacted some of its employees. So by the end of this presentation today, it is hoped that most of you would be liberated with knowledge and ideas to reduce the inevitable impact of age-related eye disorders in the community. Some of the questions that we asked during the research was, what is the level of knowledge regarding age-related eye diseases among employees at the Princess Margaret Hospital and SRC, Sunderland's Rehabilitation Center? What are the attitudes towards age-related eye diseases among employees at PMH and SRC? What are some of the self-care practices regarding age-related eye diseases of the employees at those 2 institutions? What are the influencing factors associated with awareness, attitude, knowledge, and self-care practices? For example, age, gender, educational level, employment status, insurance coverage, etc., regarding age-related eye diseases of employees at these institutions. So by the way, we did some literature review and it was a lot. I think we went intensely into about 10 of them. And I tried to compact this presentation. So out of 500 slides, we reduced it to about 300. Everybody's eyes just, yes, okay. That's not true. So 16 chronic non-communicable diseases, CNCD, are presently covered by the plan. Glaucoma ranks 6th in the number of beneficiaries registered per condition as of July 31st, 2018. So the total number of persons currently enrolled in the National Prescription Drug Plan for glaucoma is over 4,000. So that's approximately 15% of all of the registered beneficiaries. Additionally, glaucoma is ranked 4th in the number of prescription claims processed monthly. 4th. So, and the total cost of medication per condition, like I said, is over 112,000. So we did a study. It was a quantitative descriptive cross-sectional study that was conducted in November 2018 over a 2-day period with the approval from the Public Hospitals Authority, University of the West Indies Research Ethics Committee. The research team consisted of 4 registered nurses, and the data was collected via a self-administered questionnaire. The population setting was, the research was done among civil servants at PMH, of course, and SRC. And we tried to include all of the employees once they were over the age of 20. The sample size was of convenient sampling, and we did much calculation with this. And thankfully, we had a local epidemiologist that assisted us with all of this calculation. A self-administered questionnaire was retrieved and reviewed in the literature by Katabe and was used. The researchers advertised the study via a flyer, and we were able to just go ahead with the study. We got approval. So I will skip most of this because I'm still trying to reduce this because all of the fun things are at the latter part of the presentation. All right, so we got the approval, like I said, and it was granted to us by the Ethics Committee on October 24th, 2018. This is just a glimpse of the tool that we use for the research, but I already mentioned the questions to you. So now we go to the findings. If you look at the slide that we have here on this bar graph, you would see that the majority of persons who we interviewed, who was given the questionnaire, actually completed about secondary level education, and that accounted for about almost 30% of the persons. And as you can see, post-diploma, which they did get some college in there, but that accounted only for about 14%, almost 15% of persons. And we're looking at also the insurance coverage because most persons don't go to the physician, unfortunately, unless they're being covered by the insurance. What do we do first? We call and we ask your physician, do you cover this by this insurance? You don't go to a hospital until you find out if you're actually covered by the insurance, right? So we're looking at this here and it's showing us that whole life insurance, about 48% of the persons actually had that. So this would help us later on to understand some of the findings. So we have another bar chart that's coming up. We ask a question, your perceived effect of vision loss. How would this actually impact you in some way? And 65% of persons believe that vision in some way, if it were lost, or I guess if they had moderate or severe blindness, that it would affect them about 65%. So thinking of that, now we go into the diseases, looking at cataract first. We ask a question, how many persons heard of cataract to find out their awareness? 89% of persons knew of cataract. But then you ask to give a simple definition of cataract. Only 14% of persons actually knew what cataract was. Do you believe that cataract can cause vision loss? 23% of persons. They thought it was treatable. 84% of persons, over 84% of persons thought that it was actually treatable. And then where did you get your information when you heard about the cataract? The 25% said they heard it from their medical practitioner. And when we outlined the different persons you would be hearing this from would be your ophthalmologist, your optometrist, and your general practitioner. So 25% heard from that, 25% from family and friends, another 24% from books, magazines, or other literature. And only 15% said media was the source of information. So I guess many persons don't Google cataract these days. So looking at diabetic retinopathy, which was interesting because cataract was, sorry, let's not skip to that one yet. Cataract was 89%. So looking at diabetic retinopathy, 58% of persons said they heard of diabetic retinopathy before. Now, giving the right correct definition of it, only 32% actually knew what it was to give a simple definition. And so the question was asked, do you believe visual loss was a presenting symptom for diabetic retinopathy? 44% said yes. Do you believe it's treatable? 84% of persons believe it was treatable. Now looking at the source of information, two major sources, medical practitioner once again, and then of course, family and friends. So we're thinking here that persons, because diabetic retinopathy, we don't really discuss that over the family table. You probably discuss glaucoma or cataract. So maybe somebody may have gotten ill in the family, and that's probably the way how they heard about it. Because now the 21% saying from family and friends, maybe they heard of the diagnosis through a sick loved one. Now we get to glaucoma. We all know that most persons in the Bahamas has heard of glaucoma before. Okay, that is like almost the most popular eye disease in the Bahamas. 90% of persons heard about glaucoma. But now look at this. Only 25% of persons knew what glaucoma really was. So we asked the question, do you believe that vision loss was the initial presenting symptom? 40% believe that vision loss was the presenting symptom. So they're not going to be believing that you have glaucoma unless you probably have some vision loss there or you're blind. That is something to look at. Then we asked, was it treatable? 92% believe it's actually treatable, which is great. Now, where did you get your information? Glaucoma had the highest percentage of 29%, got it from their medical practitioner. So more than likely they got it from the general practitioner, the ophthalmologist, or the optometrist, which is great. 22% family and friends, and only 21% got it from books or magazines. Now, book or magazines may also cover the internet, all right? So that figure is kind of low there. So that is the findings for our study, but then it gives a lot of discussion to go along with this, because looking at all of this information and getting these results, it's kind of startling to a person, actually for all of us as medical officers and other persons in health. A larger sample size, we believe next time that we need to select a larger size in order to do the study again. I'm eager to do the study right now to find out what's going on in other areas in health and also in other government facilities. We need to disseminate the findings of the study to improve healthcare policy, to advocate changes to the prescription drug plan to include age-related eye diseases, because this year is impacting us. How many persons you see packing into the eye care center and other places, or scrapping in Lowe's, I mean, not say the name of the pharmacy, I withdraw that. Scrapping in the pharmacy to try and afford medication in some way, putting back something vital in order to pay for these medications. To advocate the inclusion of ophthalmic conditions in the national health insurance. That is sad also because you have persons who go there and they're assessed from head to toe, all kinds of investigations done, but when it comes to the eyes, it's left out. Advocate for more specialized training of staff in ophthalmology. And that is true because the study actually said that around 25% up to 29% of persons actually get their information from the medical practitioners. And that would also include persons like nurses. The nurses were not listed in that particular tool. So when they asked, when they were filling it out, if I got it from a nurse, a family nurse or something like that, can I put it as that? And yes. So that means that they're getting the information from us. And so more of us need to be trained and also exercise the knowledge that we have. We need to increase the access to healthcare among the visually impaired, because now we know that many persons are impacted by these age-related eye disorders, but then they're limited because of their vision impairments. To regulate the sustainability of eye care in public health clinics, hospitals throughout the Bahamas, we must do that because if we have adjustments, let's say, for example, this pandemic, right now we have no eye clinic going on right now and throughout the community clinics. We have no ophthalmologists and other things present, and that is because you have to make adjustments as major things happen in the country. But because this is so essential and these eye diseases are not holding off, things are still going on. Listening to the other presentations already today, not just because COVID or something is around means that persons are no longer looking at these electronics, that diabetes is not going on, other CNCDs are not going on, it's still happening. So the conditions are only worsening. So we need to be able to maintain and sustain these types of clinics and services. to maintain regional and global standards of care through policies, societies, committees, and campaigns tailored for eye health. And I think the Bahamas is doing a good job in trying to organize a lot of these things. I told you this was a very short presentation, right? I got to compact it into very little to get to the point. So in conclusion, awareness of cataract, diabetic retinopathy, and glaucoma within the cross-section of the workforce studied at the PMH and SRC is very high. The knowledge of these conditions and self-care practices are average. These eye conditions contribute substantially to the growing number of persons who will eventually become blind, according to whom. So therefore, continuing education through health screening, pre-clinic talks, community outreach, social media blitz, and go on with symposiums and other seminars just like this can and may improve the existing knowledge that can have a positive impact on attitude, knowledge, and self-care practices of government employees, and that's actually us. So we need to start with us first, and once we start with us, then it will trickle down to the community and elsewhere. Okay, so I will take questions if you have it while I say this last slide that I missed. So the therapeutic relationship that was forged between respondents and the attending healthcare professionals was evident. Subsequently, the majority of persons received their information from an ophthalmologist, optometrist, or general practitioner. So the amount of persons trained within these specialties should be increased to sustain the impact of healthcare professionals on eye health care, which was noted in the study already. Now I will take those questions. And these are the researchers here. We have Nurse Olivia Gator, Nurse Italia Gordon, and Nurse Rochelle Wallace. They were the researchers for this study, and myself, of course. Questions?
Well, we've come to the end of our presentations for this afternoon, and our final speaker is going to come on in a few seconds. Diabetic retinopathy is a leading cause of vision loss globally of an estimated 285 million people with diabetes mellitus worldwide. Approximately 1/3 of diabetic retinopathy is vision threatening. Diabetic retinopathy, including diabetic macular edema. This is from the Eye and Vision on Google 2015. Our final speaker will update us on the treatment of diabetic retinopathy. She is a consultant, ophthalmologist, retina specialist at the Princess Margaret Hospital, completed ophthalmology residency at Maulana Azad Medical College in 2013, obtained subspecialty vitreoretinal training 3 years at Guru Nanak Eye Center in Maulana Azad Medical College, reviewer of many reputed retina journals. Welcome, Dr. Supriya Arora.
Good afternoon, everybody. So I'm going to be presenting on management of diabetic retinopathy. Diabetic retinopathy is the leading cause of visual loss in working age population. Diagnosis is made by clinical manifestations of vascular abnormalities in the retina. It is clinically divided into 2 stages, non-proliferative and proliferative diabetic retinopathy. Non-proliferative, which is the earliest stage of diabetic retinopathy, is characterized by increased vascular permeability and capillary occlusions in the retinal vasculature. Retinal pathologies include microaneurysms, hemorrhages, hard exudates. Patients may be asymptomatic at this stage. Proliferative diabetic retinopathy, or the most advanced form, is characterized by neovascularization. Severe visual impairment due to vitreous hemorrhage and tractional retinal detachment can happen. Diabetic macular edema is a condition which can happen in either of the stages, either in the non-proliferative stage or in the proliferative stage, and is the most common cause of moderate visual loss. So proliferative diabetic retinopathy is a cause of severe visual loss, and diabetic macular edema is the most common cause of moderate visual loss. So I'm just going to be showing how do we diagnose these conditions. So if you can see the tiny red spots here, these are called as the microaneurysms. So even if we have a single microaneurysm present, we call it as a mild non-proliferative diabetic retinopathy. For calling it as a moderate NPDR, there should be several retinal hemorrhages in 1 or 3 quadrants. There should be venous beading, which are looping of the veins, or they could be cotton wool spots. For diagnosis of severe NPDR, one of the following characteristics should be present. There could be severe hemorrhages in all the 4 quadrants, significant bleeding in 2 or more quadrants, or moderate intraretinal microvascular abnormalities in 1 or more quadrants. We call it very severe if 2 of these criteria are satisfied. Proliferative diabetic retinopathy, if you can see the tiny frail and fragile vessels here, this is called as neovascularization elsewhere. So what happens in proliferative diabetic retinopathy is, because of the tiny capillary occlusion, retina is not receiving enough oxygen. When retina is not receiving enough oxygen, it's a body's compensatory mechanism to produce new blood vessels so that retina can receive oxygen. However, in this process, new vessels are formed, but these new vessels do no good to retina. In fact, these new vessels are very fragile and they bleed. In fact, they make the eye worse. So once they bleed, it leads to vitreous hemorrhage, and once they pull onto the retina, it causes a tractional retinal detachment. These are pictures of high-risk proliferative diabetic retinopathy depending on what the size of the neovascularization at the disc and neovascularization elsewhere is. So this is an indication for urgent treatment. Macular edema, we say that a patient has clinically significant macular edema if the thickening of the retina is at or within 500 microns of the center of the macula, or there are hard exudates at or within 500 microns of the center of the macula with associated retinal thickening, or there are zones of retinal thickening, one or more, 1 disc diameter or larger in size, any part of which is within 1 disc diameter of center of macula. Now we're coming on to the investigations. This is fundus fluorescein angiography. This is done by injecting a dye intravenously, and once the dye is injected in the vein, it reaches the retinal vasculature. First, it goes to the retinal arteries and then to the veins. So if there are any abnormalities in the vessels, that will be outlined in fundus fluorescein angiography. So this is just to show that basically there are 10 layers in the retina, and there are 2 kinds of blood retinal barrier. There is an outer blood retinal barrier and there is an inner blood retinal barrier. So in case of diabetic retinopathy, it is the inner blood retinal barrier which is affected. So these capillaries here, they become leaky, and when they become leaky, they can be caught on the fluorescein angiography. So fluorescein angiography is not required to make the diagnosis of macular edema, because macular edema is a purely clinical diagnosis. However, fluorescein angiography is required to guide the treatment of macular edema and to assess the status of macular perfusion, if there is any macular ischemia or not. Similarly, fundus fluorescein angiography is not required for the diagnosis of proliferative diabetic retinopathy, which is a clinical diagnosis. However, if the patient has a cataract or some corneal haze and we cannot get a good view of the fundus, then this investigation is useful in highlighting neovascularization. Sometimes the patient has unexplained visual loss. We cannot explain the visual loss of the patient based on the clinical findings. So in that cases, fluorescein angiography may reveal a macular ischemia. So this is just to show how fluorescein angiography can help in guiding the treatment. On fluorescein, if you see here, there are some yellowish hard exudates present right at the macula. When we did the fluorescein angiography, we found that there are some microaneurysms which are leaking. This is another picture. If you see these white things, they are leaking. These are the leaking microaneurysms, and they can be targeted directly while treating the patient. This is another picture showing, again, hard exudates are present at the macula. When we did the fluorescein angiography, we saw a diffuse leakage. So focal leakage versus diffuse leakage, there are different treatment to be planned for both of them. This is another picture showing diffuse leakage and fluorescein angiography. So looking at this clinical picture, we may not be able to say that why this patient has a severe visual loss. But once we do the fluorescein angiography, we can see, if you look at these black areas, these are the capillary non-perfusion areas. That means capillaries are absolutely non-perfused here. They're not receiving blood here. This is just to show you an enlarged view. Like, this is the normal area, and here is the capillary non-perfusion area involving the macula. So that's the reason for patients' very low vision. Another picture showing macular ischemia. It's a very poor prognostic sign. Even if we treat the patient, usually the visual gain is not very good if there is a macular ischemia. Similarly, fluorescein angiography is not required for the diagnosis of proliferative diabetic retinopathy. We can see the neovascularization elsewhere clinically here. And once we do the fluorescein angiography, you can see a bright leakage. So this is just for confirming. However, as I mentioned, if the patient has a cataract or any other media opacity and we cannot clearly see neovascularization, then fluorescein angiography is very helpful. It is also very helpful in medical legal cases. This is an advancement in fluorescein angiography. So the conventional fluorescein angiography is able to visualize only the central portion or the 75 degrees of fundus. But this advancement of fluorescein angiography, called as the wide field FFA, is able to visualize even the far periphery. So this far periphery areas, so the far peripheral area, and there are very tiny neovascularization elsewhere. This is so tiny that it is very easy to miss it on clinical examination, and this will surely be missed on a conventional fluorescein angiography. But on wide field FFA, we can pick this up and we can treat the patient accordingly. So this is for targeting laser treatment here. OCT, or optical coherence tomography. This is literally like I would say an optical biopsy, which we are doing very conveniently. All patient has to do is just put their chin on the machine, and it's a camera which captures a picture. And we can get, this is the picture, this is the kind of picture that we get. So what we were able to obtain with histology or with a biopsy, now we can obtain with just a camera. So this is the role of an OCT. We can see various layers of the retina, and wherever the pathology is, we can easily identify, okay, it's in this layer and this is what the treatment needs to be done. So there are 4 patterns of diabetic macular edema noted on OCT. Why it is important to do the OCT is, firstly, there are 3 types of macular edemas which can be treated medically. But there is one type of macular edema called as the Witcher macular traction, which can be treated only surgically. So this is why we need to do the OCT. Second thing why we need to do the OCT. Okay, I'll just come on to that. So I'm talking about the advancements in OCT. So if you look at this, the top picture, green picture, and this black and white picture, there is a lot of difference, okay? The top picture is that of a time domain OCT, or the previous generation OCT, while the lower picture is that of a spectral domain OCT. There is a lot of difference. If you look at it carefully, you're able to see all the layers very clearly in this, and you can actually make out how much the damage is and therefore plan your treatment accordingly. But with the previous generation OCTs, you were able to make the diagnosis, but the precision was not good. So you don't know how much exactly the involvement is in. So how does OCT decide treatment? OCT does a qualitative assessment and a quantitative assessment. Qualitative assessment, I just showed you the 4 types of macular edema. It will help us decide whether the patient needs to be taken up for surgery or patient can be treated medically. For quantitative assessment, we actually look at the thickness of the macula. If the thickness is more, then we need to give intravitreal drugs to decrease the thickness. If the thickness is less, then laser could be an option. OCT is also used for monitoring the response to treatment. If you look at the first picture, here you see diabetic macular edema that is significant with cystoid macular edema and serous retinal detachment. However, once we give the intravitreal injection or do some other treatment, then the macular edema comes down. So OCT is very helpful in monitoring the treatment. This is a new investigation called as the OCT angiography. So it is combining both the OCT as well as the fluorescein angiography. The most important thing about it is that it is not using any dye. So when we are using fluorescein angiography, we are injecting a dye in patient's arm that is subjecting a patient to maybe allergies. There may be an anaphylactic reaction. There could be severe nausea. Patients who are on renal dialysis or of congestive heart failure, they are at risk, so they cannot be easily taken up for fluorescein angiography. OCT angiography is very convenient because just like the OCT, they just have to put their chin and a camera has to take a picture. So OCT angiography is a very good technique for that matter. Apart from that, when we do fluorescein angiography, we are able to visualize only the superficial capillary network. But when we do the OCT angiography, we are able to visualize the deep capillary network also and the peripapillary network. So it has certain advantages. But the disadvantage is that it is able to visualize only the posterior part of the retina, not the peripheral part. So when we were doing fluorescein angiography in proliferative diabetic retinopathy, or when we were doing the wide field FFA and looking at the peripheral areas for any neovascularization, which were difficult to pick up clinically, OCT angiography is not going to help with that because it is only able to visualize the posterior part of the retina. These are some of the pictures. The first picture is that of fluorescein angiography. The next 2 pictures are of OCT angiography. This is the superficial layer, and this one is the deep layer of shown in OCT angiography. So the treatment options, we have to treat only 2 things in diabetic retinopathy. One is the macular edema, and the second is the proliferative diabetic retinopathy. I will discuss proliferative diabetic retinopathy first. So the gold standard for treatment of proliferative diabetic retinopathy is laser or pan-retinal photocoagulation. Okay, there is also an option of giving anti-VEGF injections, but I will come on to what are the pros and cons of giving anti-VEGF versus doing a pan-retinal photocoagulation. Second thing that we can treat is the macular edema. The treatment option, the first line treatment is the anti-VEGF agents. Then there is an option of intravitreal steroids, and then laser is also an option. So when we go ahead and treat diabetic retinopathy, first thing is the systemic control, the lipid profile, cessation of smoking, renal function, anemia, and needless to say, blood sugar and blood pressure. So these are the most important things which have to be controlled. If these parameters are not controlled well, whatever treatment we may do, the treatment is not very effective. So for diabetic macular edema, the treatment of choice is anti-VEGF agents. It is injected intravitreally. We do that in the operating theater here. So current evidence shows that anti-VEGF therapies reverse visual impairment in addition to stabilizing and preventing future vision loss. These are the various types of anti-VEGF drugs. So the last 3 are the ones which we use in the public system here. We have bevacizumab or Avastin, which is available. Now, bevacizumab or Avastin was actually designed as an oncology drug for a colorectal carcinoma. We are using it off-label in the eyes. It is not FDA approved, but many studies have been done to show that it is safe. We are using it because it's a cheaper alternative and is available. These two are the FDA approved drugs, but many studies have shown that Avastin is also equally effective. Although the side effect profile of the other drugs is slightly better, especially in patients who've had a stroke or a myocardial infarction. For them, studies had shown more mortality with Avastin. But yes, all the three are options. In terms of efficacy, all three are good. So it is also like that suppose we're giving Avastin to one patient, we've tried 2 or 3 injections and the patient is not responding very well. So then it is advised to change the drug because the patient may be refractory to one kind of drug. So we may try another kind. The same thing holds if we're using ranibizumab for one patient and we've given 3 injections and patient is not responding, then we may try Avastin. So it's vice versa. Limitations of anti-VEGF agents is the foremost limitation is the multiple injections. Injections are required every month. Now, here I face a lot of problems because a lot of times patients are not controlled, their diabetes is not controlled, their blood pressure is rocket high. And if I'm planning them every month, when they come to get the injection, they are not controlled. So this is one challenge that I face. Second thing is the cost. And third thing is that a patient may be a partial or non-responder to one drug or the other. These are various studies to show that anti-VEGF agents are the first line drugs. Why I'm showing these studies is because previously, laser used to be the treatment of choice for diabetic macular edema, which has now completely been replaced by anti-VEGF drugs. However, laser still holds a position. I'm going to be discussing why. I talked about the focal leakage and the diffuse leakage in fluorescein angiography, right? So the focally leaking microaneurysms are very responsive to laser. They are very responsive to laser, whereas the diffuse leakage is more challenging to treat with laser. The mechanism of action of macular laser is very, very, very different when we're doing laser for a proliferative diabetic retinopathy. In pan-retinal photocoagulation, or the laser which we're doing for proliferative diabetic retinopathy, our purpose is to ablate the retina. But here, when we're doing the macular laser, our purpose is to stimulate the retina. So that we are trying to stimulate the RPE pump, we are trying to stimulate the endothelial cell replication so that inner blood retinal barrier can be maintained. So we are doing very mild laser when it comes to macular laser. This is just to show how when it's a diffuse leakage, we do a grid laser, and when there are leaking microaneurysms, we do a focal laser. If you look at this, fluorescein angiography, you will see focally leaking microaneurysms. So look at these, the ones highlighted in yellow. So these are the areas which can be targeted with laser. But it is very important to understand that laser is not effective if retinal thickness is high. So for the laser to be effective, first retinal thickness has to be brought down, maybe with an anti-VEGF. This is another picture showing how when we did a modified grid, we did a grid laser here, and then we targeted the focally leaking microaneurysms. Some clinical pictures, if you see hard exudates here and you see leakage here on the fluorescein angiography, once the laser was done, you see the resolution of macular edema and you see resolution of leakage in the fluorescein angiography. However, laser does have limitations. That's the reason why anti-VEGF have taken the first place instead of lasers for macular edema. Limitations include poor quality of vision, infrequent visual recovery, relatively ineffective in diffuse leakage, or recrudescence or persistence of edema. Answer to the first is a sub-threshold laser. No, now it's not necessary to use a full threshold laser. There are a lot of advancements in laser. Sub-threshold laser is a laser mark that you cannot actually see. Even the physician who's doing it, he also cannot see. Okay, they are that mild. They are that mild, and there is no evidence to pick it up. Like, you know, even a fluorescein angiography cannot pick it up. Yes. So, but it is because the problem with the macular laser is because right at the fovea, we cannot afford to have a higher laser power because that will lead to scarring right at the fovea. And that was the cause of infrequent visual recovery. When our purpose of doing a macular laser is slight stimulation of the retinal pump, retinal pigment epithelium pump, so that inner blood retinal barrier and outer blood retinal barrier is maintained. And we're trying to stimulate capillary endothelial cells. So very, very mild or subthreshold laser works really wonders. For infrequent visual recovery, intravitreal anti-VEGF is the answer. For ineffectivity, again, anti-VEGF or intravitreal steroids. For persistence of edema, we can use a combination of the two modalities, anti-VEGF with the laser. So this is about subthreshold micropulse laser. So if a patient has a very good visual acuity, we will be hesitant in giving an anti-VEGF injection inside the eye, because whatever we may say, there is always a small risk of introducing an infection. There's a very minimal risk of retinal detachment, which is hemorrhage. And if a patient has a good vision, we or the patient, might not be prepared for even slightest of risk. So subthreshold micropulse diode laser is a very good answer for that. And as I said, it can be done right at the fovea without causing a foveal scarring. I have personally done this laser in hundreds of patients when I was in India, and this used to be my favorite. I have published many papers on this as well. This is just to show that it is safe to use it even when the visual acuity is better than 20/40. Intravitreal steroids is another option because sometimes the patient is refractory to anti-VEGF. We need to try other drugs. So intravitreal steroids is an option. One side effect of steroids is cataract and glaucoma, definitely. But if we use it in pseudophakic patients or the patients who've undergone a cataract surgery, then the chances of cataracts are not there. But glaucoma is still a limitation. So the rationale behind using combined anti-VEGF with the laser, what it does is if we use an anti-VEGF first and then we use the newer or the recent modalities of later after that, it decreases the treatment burden. We don't need to take up the patient every month for the injection, and it gives a sort of permanency to the treatment. So instead of taking the patient every month for the anti-VEGF injection, we can use anti-VEGF injection to bring down the retinal thickness. And once the retinal thickness is low, then a subthreshold laser can be done, especially if there are focally leaking microaneurysms, because laser is very effective when the leakage is focal, not so much in the diffuse leakage. Similarly, we can the combined modality can be with anti-VEGF with laser or intravitreal steroids with laser, especially if it's a pseudophakic eye. Other options include intravitreal implants. So there are implants, now the anti-VEGF agents, they have to be given every month, right? These implants, their effect lasts for about 3 months. So once we inject in the implant, it may stay in and we don't need to take up the patient repeatedly. However, limitations include, again, cataract, glaucoma, and they are expensive. So when I showed you the wide field FFA picture, so if we are ablating the capillary non-perfusion areas with pan-retinal photocoagulation, it is not only helping in proliferative diabetic retinopathy, but is also helpful in macular edema. So this is pictures showing proliferative diabetic retinopathy, and we have to immediately treat high-risk PDR. So proliferative for pan-retinal photocoagulation, when we do laser marks in beyond the arcades, and they are one burn width apart. And we normally do pan-retinal photocoagulation in about 2 to 3 sittings per eye. It is slightly painful for the patient. We use a topical anesthesia to do the laser, but it gives a permanency to the treatment. Now, an advancement in the laser is multi-spot laser. So in the conventional laser, we are giving 1 spot at a time. In the multi-spot laser, we can give up to 56 spots at a time. So the treatment is much faster. So instead of 3 in 3 sittings, it can be done in 1 single sitting, and it is much less painful for the patient. Patients prefer this a lot over the conventional laser because, again, they don't have to come again and again. It is faster and it is less painful. This is the next generation laser, and this has literally revolutionized the laser treatment. This is called as the navigated laser system, or NAVLAS. What it does is that it is a computer assisted. Sometimes even a contact lens is not required in patient's eyes. Patient just puts their chin, like the sit for an OCT, they just put their chin and they look in the center. Sometimes even a contact lens is not required. They localize the location. Doctor marks what is to be lasered on the computer screen. The doctor also doesn't have to bend down. They just have to mark on the computer screen, and it is highly precise. And again, it can be done very fast, even in a single sitting. Both the eyes can be done very fast, and people call it painless. I'm sure it's not painless. It causes very little pain, but it has been propagated as a painless laser. And apart from that, it also has the sub-threshold laser. Like I was talking about for macular edema, we can use a sub-threshold laser. So sub-threshold laser facility is available in NAVLAS. Role of vitrectomy. Now, vitrectomy or surgery is done for vitreous hemorrhage, for tractional retinal detachment involving or threatening the fovea, combined retinal detachment, subhyaloid hemorrhage or hemorrhage, which is preventing completion of pan-retinal photocoagulation. So when we do the surgery, we always prefer to give an anti-VEGF agents 2 to 7 days prior to the surgery. Because what it does is that it decreases the chance of bleeding during the surgery. And but the disadvantage is that it increases the fibrous component of the tractional retinal detachment. So the tractional retinal detachment may get worse. So whenever we are planning a patient for surgery, I always get the patient cleared for surgery first, then plan an anti-VEGF, and then plan for surgery, because I never want that I give an anti-VEGF to the patient and then the patient for some reason is not cleared for surgery, because that may worsen his tractional retinal detachment. If it was not involving the fovea earlier, or it was just threatening the fovea, after me giving the injection, it may involve the fovea. So always the patient has to be kept ready for surgery whenever there's a tractional retinal detachment and we know that it may worsen. So this is the same thing as I told you, 2 to 7 days before the surgery, I plan an anti-VEGF injection. So to conclude, systemic control is of foremost importance. Ocular investigations include fluorescein angiography and OCT, and now OCT angiography is combining both of these. In case of diabetic macular edema, if there is no center involvement and the leaking microaneurysms are present far from fovea, then laser is a very good alternative. However, if the center is involved and visual acuity of a patient is worse than 20/30, then anti-VEGF can be given. However, if the center is involved, but the visual acuity of the patient is better than 20/30, then we don't like to give an anti-VEGF. Then we can do a laser. So for a combination of treatment, if the thickness on the OCT is less than 350 microns, we can, and there is a focal leakage which is present, we can straight away go ahead with laser. But if the thickness is more, or there is diffuse leakage, or there is an associated proliferative diabetic retinopathy, then first an anti-VEGF has to be given, followed by laser. So for proliferative diabetic retinopathy, pan-retinal photocoagulation remains the gold standard. Why I say that is because anti-VEGF is also an option, and many studies are coming up which are giving monthly anti-VEGF injections for proliferative diabetic retinopathy. But this is, I would say, as compared to macular edema, which causes a moderate visual loss, proliferative diabetic retinopathy causes a severe visual loss. We have to keep the patient on a very, very strict follow-up if we decide to give only anti-VEGFs. Because when we delay the treatment between two anti-VEGF agents, the neovascularization may come back. If the patient doesn't have an access to doctor at that time, he may bleed. So PRP is the gold standard because it gives a permanent treatment. There is a side effect because sometimes a little peripheral vision is lost when we do the pan-retinal photocoagulation, but we are trying to preserve the central vision by giving a little compromise. Vitrectomy can be done for tractional macular edema or refractory macular edema. Otherwise, the indications of vitrectomy include vitreous hemorrhage, tractional retinal detachment, or combined retinal detachment. Thank you. Any questions? Thank you. Macular edema and steroids?
What I wanted to know is generalized steroids, are they useful or they must be injected?
No, I'm not talking about oral steroids at all. I'm only talking about injectable intravitreal steroids in diabetic macular edema. So as I said, anti-VEGF agents are the first choice. Sometimes a patient is refractory. Then intravitreal steroids can be tried in those cases. Also, intravitreal steroids can be in the form of intravitreal triamcinolone, which is very short acting and has more side effects because it releases the steroid immediately, versus intravitreal implants like Oziodex, which release steroids slowly. And so, yes, it can be tried in cases which are not responsive to anti-VEGF agents, and they are useful. In fact, I would say a lot of times they are equally efficacious, but because their side effects are more, that's the reason why we prefer anti-VEGF agents.
And if I can ask, the type of laser that you used in India, exactly what is the name of it that you used?
Subthreshold laser.
Okay.
Subthreshold?
Yeah.
Below the threshold.
Right.
Subthreshold.
How costly is a laser like that compared to the PRP that we use?
No, the cost-wise, it's not very costly like that.
I mean, not to give it. I mean, like the laser machine itself or whatever. Is it more costly than the PRP?
No.
It's
if
not?
No, it depends. So if you're talking only about the subthreshold laser machine versus the pan-retinal photocoagulation machine, the machine only for subthreshold laser is not very expensive.
But you find that it is more effective than the PRP?
No. See, they are completely different reasons.
Okay, go ahead.
PRP or pan-retinal photocoagulation is for proliferative diabetic retinopathy, whereas the subthreshold laser is not effective in proliferative diabetic retinopathy. Subthreshold laser is for macular edema. Okay, so it is for diabetic macular edema. It is very useful for central serous chorioretinopathy. It can be used in macular edema due to vascular occlusion, but it cannot be used for pan-retinal photocoagulation. So they cannot be used in replacement because they have different uses.
Thank you for the clarity. Thank you.
Thank you.
Okay, great. This has been a wonderful research day. I hope it's many more to come. So I'd just like to give the vote of thanks. I'd like to first of all thank all the speakers for all their excellent presentations. Dr. Darren Halliday for his technical expertise. Ms. Tashnell Hamilton and Novartis support for this event, for their support for this event. Dr. Robin Roberts and the UWI staff for all their assistance and support. Ms. Hamilton and her team here at the PMH Medical Library. Staff at the Bahamas Medical Council, the Research Day Committee persons, entire team at the PMH Eye Care Center who all contributed to the success of this event. Thank you one and all. Dr. Green will now come with the closing remarks.
Thank you very much, Portia. Yes, indeed, this was an excellent and fantastic research day. And we do look forward to the next one in 2021, Ophthalmology Research Day. And it was quite wonderful. Yes, it was a great start to that. And it was quite wonderful to see our viewers online. We had a sizable audience that stuck with us throughout the day. And I was very excited to see people from as far as Exuma, Grand Bahama, as well as Canada. So thank you. Excellent day to everyone who contributed to this event. To God be the glory.